Good morning to everyone. Welcome to the first official meeting of the President's Task Force on Healthcare Reform. Though I am not officially a member of the task force, the First Lady, who is the chairperson, has asked me to be here in her place. She regrets very much that her father's illness prohibits her from being with you here today. As you probably know, we have a very full schedule. More than 60 groups are scheduled to testify, so we have had to schedule testimony very tightly and ask that each witness in each panel come to the table promptly, please, when you are scheduled to speak so that we can stay on time. If you are speaking today, please limit your opening remarks to 3 minutes. There will be time for further discussion in response to questions from this panel during each panel's discussion. The timers in front will indicate by turning yellow when 1 minute remains. The red light indicates that your time is up. We have set these limits in order to ensure that there is adequate time for discussion and for exchange and for questions. For those of you who have more to say, we are accepting written statements, and you should feel free to submit them. I guarantee you they will be read extremely carefully. There will be assistants around the room to receive your statements for our record. Finally, let me take a minute to announce that beginning today, we will have a public reading room containing documents of the President's Task Force on Healthcare Reform. Specific information regarding this room and its location at the Humphrey Building at HHS is available in the registration area today. Many of the documents relating to this public meeting are in the reading room. The rest will be available as soon as possible, and throughout the next week, task force documents will be transferred to this reading room, and after that time, the materials will be periodically updated to include records that subsequently become available. Now that we have established the ground rules for today's hearing, let me just say a few words of introduction. First, let me thank each and every one of you here today to present testimony, and those of you who are here to listen for coming and attending this open session today. There is perhaps no greater sign of the urgency of healthcare reform than the vast interest the work of this task force has generated. As you know, on January 25th, President Clinton asked the First Lady to chair the task force on national health care reform. The President's charge to the task force was clear: build on the work of those groups and leaders who are committed to health care reform. Reach out and listen to all sides. Seek out the very best advice and prepare comprehensive health care reform legislation that we will submit to Congress at the end of 100 days. Since that time, we have launched an ambitious process to gather information and sort through the options available for sweeping health care reform. This process is unprecedented in recent history and has shown our intention to say clearly to the people who chose us to govern that the days of business as usual are over. We are determined to bring this country sweeping and comprehensive health care reform. Where legislation has been more often than not the product of quiet deliberations by a few people huddled in a dark room, our healthcare task force has reached instead literally across the country. We have brought together the real-world expertise of more than 500 people who receive and provide health care: consumers, doctors, nurses, social workers, hospital administrators, and more. And we have brought together representatives from all of the different parts of the different federal, state, and local agencies who are involved in providing health care to the American people. As part of our exhaustive outreach process, Mrs. Clinton and other members of the task force and its more than 30 working groups have met with more than 400 groups in the last 2 months alone. We have received literally tens of thousands of pages of policy recommendations, and many of them have become the basis for discussion and policy development. We have also received more than 50,000 letters and invited some of those consumers to come in and present their views to members of the working groups. Today's hearing is yet another step in the exhaustive and inclusive process of gathering information and suggestions about health care reform. Over the course of the next 13 hours, and let me interject that we aim to stay on time and finish in time so that everyone can go home and catch the Oscars tonight. The task force will listen to more than 60 organizations representing literally millions of people. The groups we'll hear from today may not share a common view or total agreement on how health care should be reformed, but I believe we share a common vision of providing all Americans with the health security they need. Fixing this system, as you well know, will not be easy, but the American people have demanded that we fundamentally reform a system that costs too much and wastes too much and serves too few. And they are demanding as well that we make the system work better for real people with real problems. So as we listen to you today, I ask everyone in this room and those listening across our nation to keep in mind that we will succeed only if our reforms work at the crucial moment when someone falls sick and most needs help. Health care reform, first and foremost, means giving the American people the freedom from fear. If our task is complex, our goals are simple. We must guarantee health security for every American, bring down the rising costs of health care that threaten each of us, maintain the quality of care and people's right to choose their doctors, and simplify the system and cut through the paperwork. We're convinced that our health care system can be improved, indeed dramatically improved, and we are convinced that the time for action is now. So let's turn to our first panel, and let me just briefly introduce all of you and then ask each of you in turn to make a 3-minute statement. Daniel Schulder is Director of Legislation for the National Council of Senior Citizens, and this is the consumer panel, incidentally. Phyllis Torta is Director of Health and Social Policy for Families USA. Max Richtman is Executive Vice President for the National Committee to Preserve Social Security, Medicare. Peter Thomas is an attorney representing members of the Consortium for Citizens with Disabilities. Lavola Burgess is president of the American Association of Retired Persons. And Bill Kane is board member of a coalition member organization on behalf of the Long-Term Care Campaign. So, Mr. Schulder, with the National Council of Senior Citizens, you have an extra burden. As the first of many, many witnesses today, you can set the standard. 3 minutes, no more. So thank you very much for being here, and thank you for your cooperation. Please begin.
Thank you, Mr. Vice President, and it's an honor to address this task force. I should say at the start, long-term care is usually the tail end of these things, and we're honored and happy to see this as the very first panel. Mr. Vice President, your election and then Mr. Clinton's election was a turning point in our society. Older persons voted for you and for the President at the highest rate among all age groups, and they did it because they heard your message on health care reform and especially your message on long-term care. And it's important to remember that, I would hope. The National Council believes that the goal of all health services is the functional integrity of human beings. The goal is the promotion of maximum physical independence of people. Saving lives and extending lives has been the great triumph of public health and medicine in this century. In the coming century, the design of chronic care services, helping long-lived persons live with dignity, is a challenge of the 21st century, and that century is right at us. Given these points, it would be a distortion of the term comprehensive health plan to not incorporate comprehensive long-term care services, community-based services, institutional services, and home-based services. It would be like a transportation system without incorporating roads. Further, we believe that the best way to organize the total system is on the single-payer model. We think the single-payer model is the most efficient way and in the end, the most flexible way to provide services, especially because it breaks the link with employment, and that is very important in the long-term care situation. And we support the McDermott and Wellstone bills. What would this system look like? It would be nationally funded and locally administered. It would utilize nonprofit agencies for the bulk of the services to be provided, not insurance companies who have failed over the years to provide leadership in this area. It would pivot on case or care management models with collaborative planning with the families and with persons with disabilities. No planning for, planning with. It would feature flexibility to meet changing needs of persons. In this system, there would be decent pay and benefits for workers with training and upgrading. We should have no more pious long-term care programs built on exploitation of women and minorities. And this system would need a year or more to be created to create the local service programs in home care, adult daycare, respite services, and other components which dot the nation but do not cover the nation as yet. It would be committed to rehabilitative and restorative services. Maintaining helplessness is no goal of reform. It would give care and support to families who are the bedrock of the system. The Pepper Commission, Mr. Vice President, has a good example of phase-in and financing. We support that general that scheme. However, without these comprehensive long-term benefits, I think it would be very difficult to marshal support for the passage of any proposed reform bill. Millions of older persons and their families, millions of disabled persons and their families are ready to support a comprehensive bill, and that's why we're here today. Thank you.
Thank you very much, and I appreciate your statement. Now, our second witness will be Phyllis Torta, Director of Health and Social Policy with Families USA.
Good morning, Mr. Vice President.
Welcome.
And members of the task force. Americans are looking to health reform to provide them peace of mind that they can afford to take care of their health care needs. Americans will have this peace of mind only when they have the same protection from the cost of caring for a relative with Alzheimer's disease as they have from the cost of caring for a relative recovering from heart disease. The greatest unmet need is that for home and community-based care. Families USA is in the process of analyzing some new data on the use of home care services. Preliminary results indicate the weaknesses of our current system. The vast majority of people with disabilities rely exclusively on family or friends or go without assistance because of the difficulty of finding and affording appropriate assistance. Less than 1/3 of our population with disabilities use paid home care services. Those persons with disabilities who receive paid home care services paid for half of those services directly out of pocket. These out-of-pocket expenditures amounted to thousands of dollars for many. The financial burden is heaviest for moderate and middle-income persons. Families USA urges the Health Task Force to design a home care benefit that begins to address the unmet needs and financial burdens of persons with disabilities of all ages. Such a benefit would support services provided by informal caregivers and provide assistance when no informal caregiver is available. Many persons with disabilities and their families live with great insecurity about how they will afford nursing home care if they need it. It is a myth that there is a safety net for nursing home care in this country. In 18 states, Medicaid assistance with nursing home costs is unavailable to individuals with incomes over a modest flat dollar amount. The decision to enter a nursing home is one of the most stressful and emotional decisions for individuals and their families. When making this decision, all Americans are entitled to the security of knowing that they will have access to nursing home care if they otherwise cannot afford it. Private insurance is not the answer to making long-term care affordable for most Americans. Families USA analyzed whether nursing home insurance would make nursing home care affordable. Nursing home insurance failed to make nursing home care affordable for 84% of current elderly persons, for almost 2/3 of persons between the ages of 55 and 64, and for 4 out of 5 persons who will be elderly in the year 2005. This task force must not miss the opportunity to put in place the first building blocks of a social insurance program for long-term care. The task force can develop a meaningful but modest package of long-term care benefits that would cost in the range of $15 to $20 billion in net new federal spending. These benefits could be phased in after the reforms in our acute care system have been implemented, with benefits beginning first for the most needy. We believe the public is looking to the task force to provide them with this protection. In exchange, the public is willing to financially support a program that will spare them from confronting a financial crisis when they or their family member can no longer care for themselves. Thank you.
Thank you very much. Our third witness is Max Richtman, Executive Vice President of the National Committee to Preserve Social Security and Medicare. Welcome.
Thank you. Good morning. I welcome the opportunity to testify on behalf of the approximately 6 million members and supporters of the National Committee on the critical issue of incorporating long-term care into health care reform. The National Committee's 1992 member survey overwhelmingly confirmed the desire for a comprehensive long-term care public program, including respite care for exhausted family caregivers. Respondents strongly supported a full nursing home benefit that would cover more than just 3 months of benefits. Even if the benefit covered all but the first 3 months of nursing home care, 6 of 10 seniors said they cannot afford the first 3 months. However, when given the choice between a nursing home benefit or a home care benefit of equal value, respondents choose home care by more than 8 to 1. Based on this and many other surveys of our members, we recommend that long-term care begin with home and community-based care, including adult day care. With the assistance of these services, many seniors are able to remain in the community and prevent or postpone institutionalization. Over time, a wide spectrum of benefits must be added, including rehabilitative services, institutional care, assisted living, and other housing options and transportations. To contain costs, long-term care benefits should be delivered through a care management system with rates set for services and an overall set budget. We would like to see a continuum of care bridging the gap between acute and long-term care. Individuals in need of long-term care use about twice as much acute care as do their same aged peers. It may therefore be efficient and cost-effective to create a continuum of care which allows for better coordination across care settings. Fair funding mechanisms are necessary to finance a comprehensive long-term care program. This approach could encompass federal taxes, state and local resources, and nominal co-payments according to the beneficiary's ability to pay. To find the right combination is clearly a challenge. When presented with 5 financing options, National Committee members give the highest preference to increasing taxes on alcohol and tobacco, 51%. Another 39% give the highest preference to taxing estates and gifts above $200,000, and another 11% give it the second highest preference. Upper income respondents expectedly give this proposal a lower preference. Such taxes should probably be considered before value-added taxes and income taxes. Mr. Vice President, in your opening remarks, you pointed out that the task force is working towards giving American people the freedom from fear. The protection needed by long-term care coverage is a critical part, we believe, of that freedom, and we appreciate the fact that it's included and is meaningfully looked at by this task force. Thank you.
Thank you very much, Mr. Richtman. Our fourth witness is Peter Thomas, an attorney representing the Consortium for Citizens with Disabilities. Mr. Thomas, welcome.
Thank you. At the age of 10 years old, I was involved in a serious car accident, which resulted in the loss of both of my legs below the knees. With the help of a very supportive family and friends, with an excellent rehabilitation program, and with the help of assistive devices or artificial limbs, I was able to accomplish many goals that I never thought were possible lying in that hospital bed in 1974. The disability community has many points that it would like to stress in this health care reform debate, but I will limit them to a very few this morning. First and most importantly, health care for people with disabilities is not simply a long-term care issue. Rehabilitation and assistive technology should be included in the basic benefits package and should be thought of as preventive care. It will maintain and increase health and the functional capacity of people with disabilities, and in the long run, will decrease the need for long-term care. It will actually decrease long-term cost burdens. The CCD has been working with the senior community to develop health care proposals which include all people of all ages with functional limitations regardless of diagnosis or cause of disability. These proposals are based on the principle of universal coverage and universally shared risk. Number two, the principles of independence, inclusion, and empowerment embodied in the Americans with Disabilities Act have direct implications on the health security of people with disabilities. In order to further these ADA principles, a reformed healthcare system must emphasize a comprehensive array of individual and home community services, rehabilitation, assistive technology, personal assistance services, mental health services, and specialized services. Without services that advance independence, inclusion, and empowerment, inappropriate expenditures and lost productivity costs will continue to be the results. The institutional bias in the current long-term supports program results in misuse of resources. It's too expensive, too restrictive of liberty, it's outmoded, and it denies the development of individual potential. Third, people with disabilities and chronic health conditions have special health care needs that are inconsistent with the incentives inherent in the managed care settings for underservice. People with special health care needs must have a choice in the provision of health care to safeguard against this underservice. They must be able to access specialty providers and use these specialists as gatekeepers, and must have an appeals mechanism to appeal services when they're denied when they need them. Thank you very much.
Thank you very much, Mr. Thomas. Our fifth witness is Lavola Burgess, President of the American Association of Retired Persons. Welcome.
Thank you. AARP is strongly committed to comprehensive health care reform that contains costs, covers the health care needs of Americans of all ages, including long-term care and prescription drugs, and is fairly financed. The skyrocketing cost of health care, that's to families and businesses and government, is what drives the need for health care reform. But efforts to control costs will only result in cost shifting if the benefit package is not comprehensive. Long-term care, both home and community-based and nursing home care, is a family issue. To a family, there is no difference between spending $30,000 on hospital care or $30,000 in a nursing home. Almost 75% of both informal caregivers and nursing home residents are women. Caregivers care for their loved ones at great physical, emotional, and financial cost. And remember, when caregivers cut back on work hours or leave their jobs, this leads to lower pensions and lower Social Security benefits and higher public assistance. Polls consistently show that persons aged 50 to 64 are the most concerned about long-term care. Long-term care must be designed to control costs through a gradual phase-in, beginning with home and community-based care and starting with those in greatest need. A care management system subject to budget targets that discourages overuse of services and unnecessary institutionalization, and a payment system that promotes cost containment, not cost shifting. In contrast, a system based on private insurance will increase costs and leave millions uncovered. Many simply cannot afford the high cost of long-term care insurance. Recent experience has shown that Americans are reluctant to make sacrifices in health care unless they receive something valuable in return. Protection from the high cost of long-term care may well increase their willingness to pay for health care reform. A number of recent polls support this conclusion. For example, a comprehensive study on health care by DYG Incorporated found that including long-term care substantially increases the willingness to pay across all ages and income groups. Over the last several years, in speaking to groups around the country on health care reform, I have found that the fear of health care costs, both acute and long-term care, robs people of peace of mind. It won't be easy or free. but they want the President and the Congress to act promptly to address the fear that they won't be able to afford the health care they need. Thank you.
Thank you very much. The final member of this first panel is Bill Kane, board member of a coalition organization, speaking here in behalf of the Long-Term Care Campaign. Welcome.
Thank you. Good morning. I am here today on behalf of the Long-Term Care Campaign, which is a coalition of 138 aging, disability, and other consumer organizations that have come together to support a comprehensive social insurance approach to long-term care. The membership of the campaign underscores the fact that long-term care is a family issue that cuts across age and disability. I also serve as a volunteer on the board of directors of the Alzheimer's Association, which with AARP is a lead sponsor of the campaign. But most especially, I speak to you today from 12 years of experience as the primary caregiver for my mother and aunt, both of whom had Alzheimer's disease. My parents spent their entire life savings on expensive institutional long-term care. My father died from the stress of taking care of the woman he loved. The campaign has specific responses to the question you posed to this panel. First, including long-term care in the health reform plan is cost control. If you leave it out, you will simply add unnecessary utilization costs to the already expensive acute care system. Avoidable hospitalizations and emergency room visits, illness and injury to persons who have no care, and to caregivers who have no help. Second, you must begin with a comprehensive social insurance approach to long-term care. If you try to start with private insurance, you will automatically exclude millions of Americans who are most threatened today. And you will be creating the same kind of mess in long-term care that we are now trying to straighten out on the acute medical care side. Third, you can phase in a long-term care system over time. That is important, not just to control costs, but to make sure that we are carefully building an efficient, solid delivery system. Fourth, you can get rid of the institutional bias in the current system. The place to start is with home and community care. That is what people want. That is what my family wanted. It is more appropriate, and in most cases, it is far less expensive. Long-term care services and supports in the community allow families to continue their role as caregivers instead of turning the whole job over to paid providers. And they allow many persons with disabilities to live independently and productively. Fifth, you can stop over-medicalizing long-term care. Consumers and their families need to be able to choose the services and supports that will most effectively meet their needs at the best price. And sixthly, you can make certain that the consumers of long-term care are directly involved in the overall design of the system and in their own individual plans of care. No one has a greater interest in cost control than the people who are actually paying the bill. The President has clear goals for health care reform: to control health care costs, to provide security and peace of mind to every family member, and to maintain quality. The only way he can accomplish those goals is to include long-term care in his comprehensive reform package. The Long-Term Care Campaign is committed to working with all of you and the President to accomplish those objectives. Thank you.
Thank you very much, and I want to express our thanks to all of you. We'll now have some questions, and before we do, let me introduce my colleagues here at the dais: the Secretary of Health and Human Services, Donna Shalala; the head of President Clinton's Domestic Policy Council, Carol Rasko; the Senior Advisor for Policy Development, Ira Magaziner; and throughout the day we will be joined by other members of the administration, including the Secretary of Treasury, Lloyd Benson; the Attorney General, Janet Reno; the Secretary of Labor, Bob Reich; the Secretary of Veterans Affairs, Jesse Brown; the Chairman of the Economic Advisors, Laura Tyson; the head of the National Economic Council, Bob Rubin, who will be here shortly; Tipper Gore, who has been helping to lead the efforts on mental health care reform, and some others as well. So let's start this exchange with an invitation that I want to extend to you all to disagree if you heard anything from your fellow panelists that you thought needed some clarification. If you felt in opposition to something that somebody else said on the panel, anybody want to speak up in response to that?
Mr. Vice President, I think it's clear that the issues are clear to us, and we hope it'll be clear to the panel. We've all worked in long-term care for many years. None of us are talking from a new set of experiences, but old experiences, right, both personal and organizational. So there is no real disagreement, it seems to me. It so happens among the groups picked by this task force to testify. You've
been fighting this battle for a long time, and I want to assure you that we're going to emphasize, we want to emphasize home and community-based care, and we are determined that all health issues, including long-term care, will be addressed in health care reform. We're determined that all Americans, regardless of employment status or health, will have health insurance. We believe it's wrong that Americans pay more for prescription drugs than do people in other countries, and our plan will stop drug overcharges and excessive profiteering. Those are a few of the features of the plan that I think will address many of the concerns presented by this panel. But let me turn to my colleagues for whatever questions they might have.
Let me just ask whoever wants to answer this a quick question about prescription drugs and what you think we ought to do specifically on prescription drugs.
I think, Madam Secretary, that Canada has some good models. We have provincial formularies that provide the provinces some ability to negotiate with the drug companies. There's a price review commission, a federal price review commission in Canada, and Mr. Stark and a couple of others have introduced bills to that effect. There was an aggressive provision for mandatory licensure where generic drug companies could intervene within the patent period and produce competing drugs. We can no longer allow drugs to push out of the health care package that may be designed by this task force. If the price of drugs keep going up at the rate they're going, we'll push out other services. So it seems to me we need national governmental action to keep prices down and at the same time to assure that experimentation goes on.
Mr. Vice President, I wanted to just follow up on your first question. I'd like to make a distinction, maybe it's not really a disagreement with some of the other panelists on long-term care. Public long-term care program is critical, but at the National Committee to Preserve Social Security and Medicare, we also believe that there is and could be a need for some private long-term care insurance that would fill in the gaps. At the present time, I think there are not any adequate private long-term care insurance policies. At least that's what Consumers Union has indicated time and again. So we would recommend that there be some federal standards for private long-term care insurance, even when there is a public and effective public long-term care program.
Thank you.
I just pursue that a little bit further. Do you think that the setting of standards for private insurance, in addition to some beginning efforts at public insurance, would be the right mix to go, in other words, to move on both fronts at the same time?
Absolutely. I think a mix is essential because I don't think a public long-term care insurance program will provide full coverage for every single person, and there should be some standard applied to those policies, private policies that are available. There are some efforts being made in the Congress in the last few years. The Vice President, I'm sure, is aware of this, to improve on that. There were some improvements made in a similar vein with Medigap insurance in the last Congress, and we would hope that those would be followed in long-term care.
Can I ask one other question of any of the panelists? In the mix of public and private that might be appropriate, would you see a role for the public insurance that might be more geared towards those of low income, or do you think that this should be a program that doesn't necessarily give benefit to those with low income, but rather spreads across the whole population?
Seems to me, for the National Council of Senior Citizens, our goal is a universal program covering all persons and not a means-tested program. We have a means-tested program. It's called Medicaid. It's a program which provides incomplete services with a with an institutional bias rather than a balanced bias. We already have that, sir. So that it seems to me our goal should be, in quick order, a universal program available to everybody based on need, that is physical, functional need and cognitive impairments rather than income.
I think the issues are slightly different with regard to home care and nursing home care. With home care, you're really trying to maintain someone's ability to continue to live at home. The delivery of care is much more complicated. It's much less clear that private insurance can fit that need. With nursing home care, you get to the issue, once you've taken care of spousal impoverishment and those issues, but you get to the issue of whether asset protection is a proper role for the federal government at this time, and I think that's perhaps a decision that should be put off for the future.
I heard all of you speak about the need for more home and community-based services, and I wonder if some of you would like to speak very specifically to the services you would see needed in the continuum you mentioned.
Well, I will say that from a personal perspective, and I would refer you to Senator Bradley's National Family Caregiver Support Act that we have helped develop. If you have a locally based system of case management and assessment, or care coordination, which is the phrase that's been used, you can help families very early begin to find some services that will give them some relief so they can continue caregiving at home. That might be some in-home companion care for very short periods of time during the week, ultimately perhaps adult daycare, some overnight respite care. My father was never able to take a vacation in 10 years because we just couldn't get that kind of overnight care. There are a number of services like that, including something as simple as a speech therapist coming into the home and helping to retrain an Alzheimer's person in eating so they don't require special assistance and they don't have to go to an institution. There are many things that can be done that will build up that family network of caregiving so they can stay at home longer. And then we need to develop some other alternatives to the expensive, high-tech skilled nursing facility that we do not allow for in any of our reimbursement systems, that many of our states do not allow because of regulation. There are many board and care and assisted living options that we need to develop to take care of some of these special needs that are much more cost efficient. Most of the residents, or at least 50% of the residents, like my mother in nursing homes, are persons with dementia who really don't need skilled nursing care, and they don't need to be in nursing homes, and they could be in other less expensive facilities.
I think it's very important to look very carefully at the home and community-based kinds of care. And one of the areas that bother me very much, I'm from New Mexico that has many rural areas, is that so many of those rural areas have very, very little to offer in the way of home and community-based care, where you have more of it in the cities in many ways. Certainly you need a variety of kinds of things, and we must remember, as Bill has said, that the caregiver needs a great deal of help, and we would hope that there would be a good bit of help in any kind of a reform package for the caregiver, who must not be forgotten. The adult day care, respite care, so many of these things that are absolutely crucial to keep the sanity of the caregiver must be in there to help, not just the patient, but the person who is giving that care. And I think most people much prefer to remain at home as long as possible. I know my own mother could have stayed home 2 years longer if in this little Iowa town we would have been able to have some kind of community-based care. It just wasn't there. So I think addressing that is very, very important.
I think the answer to that question is that you provide the services, whatever services are needed for the individual with either a disability or a chronic health condition, to become independent in their home or community. What we're talking about here is a paradigm shift from relying on acute care over the long term to relying on individual and community-based care that will allow people to maximize their potential, become members of the workforce, decrease costs of dependency, and social costs of that nature. And in the long-term care, costs will decrease as people become more independent.
I think one of the overlooked components, and it was mentioned earlier this morning, is adult daycare. We have found in some of the visits we've made to senior communities, especially one I recall in Mesa, Arizona, where there were several hundred individuals in an adult daycare center. Half of them probably would have to be institutionalized because they were living with their children and they needed some kind of care during the day. I think this is a very cost-effective and efficient way of taking care of large numbers of people, and in fact allowing them to, as the representative from AARP mentioned, stay home as long as possible. So I think we need to look very carefully at adult daycare and providing whatever funding is necessary to have some meaningful adult daycare national programs.
Mr. Vice President, over time, people who face chronic problems change. And one of the great needs is to maintain flexibility. We've got to arm a case manager or the care coordinator with the authority to pick out of the community a variety of services and to adjust those services as conditions do change. It was mentioned that adult daycare is a high priority or should be a high priority component. I agree. It is one of the most efficient ways to provide a range of services such as rehabilitation and counseling, nutritional services and exercise and others on a cost-effective basis, in many cases $30 and $40 a day in many communities. I have 3 adult children who are now nursing a relative who is gravely ill. And one of the needs that they have is training. How can caregivers who are not looking for any reimbursement be trained for the most effective way to deal with the long-term care need? This is in New York City. We've actually looked for that. We haven't found it as yet. But those are the kinds of things that must be available up close, up to the family. And a case manager or a care coordinator kind of agency is the important element that can provide those assistances.
Could I follow up quickly with Phyllis Torda? Some of the research on home care has suggested that it is not less expensive, but it sounds to me like everyone's talking about a more flexible model. Could you talk a little about the research and about your own research in terms of what the findings are?
Sure. One of the reasons why the research shows that home care isn't necessarily, it's not that it's not less expensive, it's that it doesn't save money, and that's because all individuals have such a natural inhibition to going into a nursing home. We don't need to establish barriers to keep people out of nursing homes. They don't want to go. And so what you have is people that are really struggling to get by, to do whatever it takes to stay out of a nursing home, and therefore it's sometimes hard to show that there's actually this trade-off between home care and nursing home care costs.
Thanks.
Nursing home care.
Let me ask a slightly different question that you have in some ways addressed already. But if we have to phase in long-term care, what priorities would you establish in determining what should be done first in a phase-in period?
Can I give you one statistic? And that is of persons with serious disabilities, 60% or so have incomes under 200% of poverty. We are, it's people as they get old, they get alone, and they get poor, and they get disabled. That's what happens. And so we're talking about a population that is really very moderate income, very old, and by and large living at home. And I think that indicates a direction in which services really need to be targeted.
We think it must be home and community-based care as a beginning, and that care management is very important there. One of the things that we're going to have to watch, of course, is that the infrastructure of much of this is not in place yet, and that's why the phase-in is very, very important, that we take our time and do it right. We also feel that in phasing in the home and community-based care, that the people having the most need should get there first. And generally those will be poor people in many cases, and that's the way we think it should be.
But if we do start with a means-based, means-tested program, we shouldn't get stuck on that theme over the years, and that's what could happen. We think, again, it must be universal and based on functional needs rather than on income. Obviously, we don't want to be spending money for those who have the resources to purchase care. But the problem is that the system has got to be developed. The system isn't there for almost any purchaser unless you're very, very rich. So to keep it at a means-tested level would simply to say, let's enhance Medicaid rather. Let's double the federal portion of Medicaid. That doesn't change the nature of the system. And I think most of us are talking about the systemic problems as well as the targeting problems and the budgetary problems.
But if you assume that you're not going to get stuck on the first or the second step, how would you phase it in?
I think you could phase it in at some level of 200% of poverty or less, providing most of the services, but quickly move out of that into a higher income level with caps on expenditures for everybody so that we can protect everybody while targeting services to low-income people at the very beginning. We can also start with 3 ADLs, activities of daily living, rather than a 2 or 1, but again, then weave into a 2 activities of daily living kind of standard later.
Given what the infrastructure is now, though, answer the question again in terms of what we could actually get started on, given what we know about what services would be available right away.
It seems to me that Claude Pepper had a bill a few years ago, which was a home care bill, which was pegged to a national cap of expenditures and pegged to the cost of skilled care, 65% of a year's time in a skilled care facility at the time. You can start out, it seems to me, with number 1, to finance the development of a case management system. That might be year 1. And then year 2, begin to provide a budget, if you will, a capitation available to everybody through a case manager to pick services from a community that may be available and to pick those services as they develop. I would work it in that sort of, we're talking about caps and global budgets. It would also, it seems to me, be appropriate under long-term care. Let me say one other thing. Under managed competition, there is no reason why the basic package of benefits could not include long-term care services. However, I'm not so sure that the system is such that you could fragment the provision of long-term care services among many providers that the HIPC, the Health Insurance Purchasing Cooperative, might pick. You may have to have within the communities specialized agencies providing long-term care available to everybody based on functional needs, but not fragmented among many, many insurance and other provider organizations.
Mr. Thomas, I think you wanted to answer the same question.
Yeah, I take this question from a slightly different tack, and that is, I need to make a distinction as a person with a disability between long-term care and care for people with disabilities that is long-term in nature. For instance, artificial limbs, and I'll go back to that simply because it's what I'm most familiar with. If long-term, if artificial limbs or durable medical equipment, prosthetics and orthotics is considered long-term care, then by all means that needs to be upfront right away. I think you need to look at functional needs, which has been parroted here before, and you need to see who can best benefit from the types of services that will allow them to maximize their potential. Rehabilitation, assistive technology, if need be personal assistance services, mental health services. So yes, those types of services need to be included right up front.
Mr. Rickman?
I'd like to make another comment on a slightly different aspect of the phasing in issue. We met over a month ago with Mr. Magaziner, and one of the issues we discussed was, of course, the high cost of long-term care. We realize it's an extremely expensive component of any health care reform proposal, and we recognize that it will probably have to be phased in and we'll not have a complete system of long-term public program immediately. But we hope that the task force will look at some definite timetables and not leave it in a vague manner, but tell us as accurately and as clearly as possible what the time frame is when long-term care will be implemented.
All right, Mr. King, go ahead.
A number of you have mentioned managed care of one sort or another, or care management, case management, and so on. I'm wondering if there are specific models of care management that you're familiar with that you think work particularly well, or whether you would suggest specific ideas on how those models might work?
One of the better models is something called Unlock, O-N-L-O-K. It's in San Francisco. It's a health maintenance organization for older persons based on disabilities, but it also provides physicians' care, hospital care, housing services. It is a comprehensive model. The problem is it is so comprehensive it may not really be replicable throughout the country. But there are also channeling programs run by area agencies on aging in many communities, in which persons can come, of any income, come to an area agency on aging, find out about what is available, and then based on whether or not they qualify for the service, get those services through the intervention of the area agency on aging. Again, there are lots and lots of models out there, and I hope that that kind of flexibility that now exists could continue under a national program. We shouldn't become rigid as we have under other medical models. This is not a medical and static situation. Thank you.
The states through the 2176 waiver programs under Medicaid have really pioneered innovative approaches to care management and have been leaders in using flexible services and designing benefit packages to fit the particular needs of individuals, and I think that's a story that really needs to get out.
I'd like to change the pace just a little bit, but because time is short, I would like to say that once this package gets out and it's passed Congress and signed by the President, I think we will need a major education thrust from the President, from the Congress, because I do believe that we must educate the public as to what's in that package, what it means, what it will do. I think people are ready for health care reform, but there's still a lot of educating out there to do. I've been out in the boonies a great deal as president of AARP, and I find that all over. People want change, but not always do they understand what change means. So the education effort, I believe, will be very, very important.
I can't recommend to you a specific model, but I can suggest some principles that need to be incorporated in the managed care setting for people with disabilities, simply because the incentives for underservice in that setting. First, choice is perhaps the largest safeguard that a person with a disability could have, choice of provider. Second would be specialists, access to specialists, and even using a gatekeeper specialist so that that person doesn't have to go through a number of tiers in order to get the care that they may need on a routine basis. And third would be the flexibility to access services that may not be available within that particular health network. For instance, I've gone to Miami, Florida for years to get my artificial limbs, and that's really the only place that I'm comfortable going after having gone to 7 or 8 different providers throughout the country, quite frankly. And to lose that in a reformed healthcare system would really, I believe, be not a positive step forward.
Peter, can you generalize about the disabled community's experience in HMOs? Are these recommendations coming out of that experience?
Absolutely.
Yeah.
HMOs have a certain amount of funds that they are paid to provide service to the average patient. And when you have people with disabilities who often require extra or routine and frequent service for particular special health care needs that may not be in the mainstream or may not be typical needs within an HMO, people with disabilities are often not referred out to specialists as they should be. They often don't get the types of services that they need, and they need to be able to access those services and have safeguards so that they can be provided the service that they need. That could take the form of an appeals process or having the ability to disenroll from that HMO and go to an HMO that better services their needs. But flexibility has to be a very important standard.
Let me ask did you get a response? Let me ask a question. Mr. Rickman, you and Mr. Schulder had a mild difference of opinion about the role of private insurance in dealing with the long-term care issue. And you are taking the position that there ought to be a larger rather than smaller role for private insurance on long-term care. Where Medigap was tried and is still available, there appeared a great many abuses in the process. You're familiar with them, your members and your members. and many of those represented here have had to deal with those abuses. How would you avoid similar or worse problems in the long-term care area?
One of the ways that the Medigap problem was corrected by the legislation that was passed in the last Congress was by putting in some standardization criteria. And I think that was critical, so that there are now a limited number of policies. Certain things have to be covered by Medigap insurance. There are certain requirements in terms of the way the policies are marketed and the choices that people understand that they have. There are certain abuses that were occurring in marketing of Medigap insurances that resulted in some individuals having many policies, 3 or 4 policies, the overlapping coverages, coverage that was provided by Medicare. It wasn't even necessary to have Medigap coverage. So I think standardizing the policies and making it clear what has to be covered and providing some marketing reforms was critical in the Medigap reform, and I think should be part of any standard package dealing with private long-term care insurance.
Mr. Schulter?
We may not disagree, but the point is that even with a squeaky clean industry that had no deceptive practices, that built in inflation, they did all the good things, it still could not be afforded except by a small proportion of older persons and, in fact, the families of disabled persons. You've got to spread the risk. That's called social insurance. And in that way, we can bring these services at a good cost to almost everybody. Yes, for a while, if we establish a baseline of public long-term care services, both institutional and community-based services, there may be a transitional role for private insurance, but the priority is on establishing a social insurance long-term care program.
Just a couple quick points on the care management issue. The systems I've seen are yet to be tested and proven because they're flooded with people who are already in crisis. And secondly, I'd like to make the point that while we want to provide a flexible model that supports the family caregiving experience, there are many, many people, elderly people out there who have no family, who have no significant caregivers, who are either lost in the realm of homelessness or inappropriate boarding home situations or in emergency rooms where they spend a lot of time. And we need to consider that. And lastly, I just would like to compliment all of you for the tremendous work that you're doing. As Lavella said, more than anything else, you really have an education challenge facing you. We all want to live long, we're all afraid of death, and we all think we need high-tech acute care. But what you're helping us do is really take a look at our value system. Between womb and tomb, we have this $900 billion bubble right here in one piece of it, and you're helping us to take a look at what we really value, what's really important. Believe me, I worked for 8 years in hospital administration and managing the practices of physicians and marketing them for higher reimbursement, playing the HCFA game and everything else. And I understand the vested interests that are there. Your wife on Friday, Mr. Vice President, called it the medical industrial complex. It tells you how things have changed today. We used to call it the military industrial complex. So changing people's values, helping us to look at what we as Americans really want in a fair way, is going to take time, is going to take a process of education. But I think you're on the right track, and I applaud you for it.
Well, we appreciate your kind words, and may I say that I think the First Lady deserves the credit for organizing this massive undertaking, of which today's all-day session is but one part. But I want to express the thanks of all of us to you for participating and for being a part of this first panel. As was said earlier, any written statements which you have to supplement the views you've expressed here are more than welcome. They will be studied very, very carefully. But with that, let me again thank all of you for getting us off to a great start this morning. Thank you very much.
Thank you.
I'd like to call our second panel up to the table now. This is a business panel. We will have actually two panels representing the business point of view during the day. This first one will be oriented a little bit more toward small business. We have been engaged in a very intensive dialogue with small businesses throughout this country, especially on the subject of health care. Let me invite the panel members to come forward. Gary Frank Petty is Treasurer and member of the Board of Directors of the Small Business Legislative Council. Margaret Smith is the Chair for Legislation of National Small Business United. Samuel Carradine is Executive Director of the Minority Contractors Association. Stephen Elmont is Vice President of the National Restaurant Association. Andra Bennett is Executive Director of the National Association of Private Enterprise. I will note here that that another organization representing small business, the National Federation of Independent Business, was invited to testify here, but declined to participate and to give their views on national health care reform. Our first witness is Gary Frank Petty, the Treasurer and a member of the Board of Directors of the Small Business Legislative Council. Welcome to all of you. I'm sure that you heard what I said at the beginning of the day about the lights and the 3-minute time limit and the yellow light, and when the red light comes on, your time is up. Thank you very much for joining us. Mr. Petty, why don't you kick it off?
Very good. Thank you, and good morning to members of the panel. I come to you...
You might pull that microphone a little bit closer, can you?
Closer, okay. Can you hear me now?
Yes,
better?
thank
Okay. Thank you for the opportunity to present the views this morning of the Small Business Legislative Council. You have copies of our background on our organization, and I'll defer your reference to that document. Let me begin by saying that we approach this debate with great optimism, because if the election of the President sent one signal to us, it is that the country would finally be united in agreeing upon the need for immediate comprehensive health care reform.
Mr. Petty,
yeah.
if you could bend them down to there you go.
How about
Maybe
that?
Yeah.
Okay. For at least 2 years, we have been preaching the need for comprehensive reform led by meaningful cost containment, and the pews have been almost empty. We are pleased that they are now filling up fast. The question today is, what is the best way to ensure that employees of small business get health coverage? In our view, the answer begins and ends with the statement, control cost. We are well aware of the number of Americans employed by small business without health care coverage. That fact, however, must be placed in context. What about the many, many millions of Americans who do receive their health care benefits through a small business employer? In comparison, this latter figure is rather significant. We are convinced that the gap would shrink even further if small employers had the comfort of knowing that the cost of coverage would not become a quagmire from which they could not extricate themselves. Further, we are more concerned about all those currently providing coverage. They have simply run out of options for controlling costs by their own actions. They have changed programs, often yearly, tried managed care, self-insurance, and cost sharing. They have absorbed all the costs they can, and unless we can control cost, all is for naught. For that reason, we have concluded that in the short term, some form of fee and price control is necessary to rein in health care provider costs. The truth is, we need to separate the health care profession from the health care business. We wish the marketplace would make these adjustments. We are not so naive to believe free enterprise guarantees the perfect system. Since 1977, SBLC has been an outspoken advocate of antitrust policy, taxation policy, such as the President's investment tax credit, and procurement policy that allow government to smooth out the market imperfections to permit a competitive economy to thrive. In this healthcare debate, we have come to the conclusion that government must undertake a role in controlling costs. We think the healthcare provider community should be asked to defend or oppose a particular cost control approach rather than the employer community. I would like to focus my remarks now on a specific small business example that cuts to the core of this issue. I can give you an example of a small business operating in Des Moines, Iowa that employs 6 drivers. The salary of those drivers ranges from $20,000 to $25,000 a year. The company does not provide health care insurance for them because of the high cost of workman's compensation insurance. The state rate is $20 Per $100 of payroll, a driver earning $25,000 a year would cost the company $5,000 a year in workman's compensation insurance premiums. The same driver would cost the company about $2,280 a year if it provided the insurance, but as I indicated, the cost of workman's comp makes this prohibitive. If the company paid the workman's comp insurance and health insurance, the total annual cost would be almost 30% of the driver's salary. If you look at all 6 drivers in this little company, the company pays about $27,000 a year for workman's compensation, or more than the annual salary of any given one of those drivers. Even with the health insurance at $250 a month, the company's annual cost would be $18,000 a year for health insurance on top of the $27,000. You combine the $27,000 for workman's comp, the $18,000 for health care, you're looking at $45,000 in annual costs for the average of 2 full-time employees. Under this situation, it's simply impossible for this company to offer both, and it's the reason it doesn't offer health insurance. If you came to this company and said, we will reduce your health care, we will reduce your workman's compensation costs in exchange for mandates, would you be willing to compromise? And I think this small business and hundreds of thousands like them would be willing to discuss that issue.
Well, that's a clear example, and it is among those that illustrates why small businesses have been so supportive of national health care reform. Our second presenter on this panel is Margaret Smith, Chair for Legislation of National Small Business United. Welcome. Please proceed.
Good morning. My name is Margaret Smith, and I'm an attorney. My law firm specializes in representing small and mid-sized businesses in Silicon Valley and San Francisco, California, where I also own 2 additional small businesses. I'm a longtime advocate of small business. Today, I'm here representing National Small Business United, a 65,000-member organization on whose National Board of Directors I sit. In addition, this year I serve as the chair of their legislative committee. For your information, health care reform has been our top federal priority for the past 4 years. Our plan for ensuring that all employees of small business have health care coverage is detailed in our written statement. In summary, it has 3 components. First, to require all individuals to have coverage. Second, to reform the insurance system so that no one can be denied coverage. And third, to institute a system of federal payments based on family income so that everyone can afford coverage. There has been some discussion of instituting a system of federal payments to small businesses rather than to individuals as a way to subsidize insurance costs. Such an approach is fraught with obstacles which we have detailed in our written testimony. Our plan puts individuals at the center of the system. The individual can be empowered to make their own health care choices. 2 key issues, cost containment and access, can be successfully handled through the formation of health care purchasing cooperatives that can easily accommodate individual purchasers. Models for these cooperatives are successfully operating in a number of regions in this country. Let me close by saying that our focus on the individual approach is not small business ducking its responsibility to its employees. Today, over 80% of small business employees and their dependents have insurance. What we are saying is what President Clinton himself acknowledged. Small business is the engine driving the country. Our responsibility is job creation in order to stoke the fires of economic growth in this nation. Our calculations show that small business will be asked to pay at least $40 billion more per year than they now pay if the burden of insuring uninsured employees is placed on our shoulders. In reality, a health care mandate on small employers will drain tens of millions of billions of dollars out of small business each year. This will put a dramatic damper on the job creation and economic growth for which this country is counting on us. We believe there is a viable alternative, the individual approach, and ask you to be mindful of this as you come to closure on the final details of your plan. Thank you.
Thank you. Our third witness is Samuel Carradine, Executive Director of the Minority Contractors Association. Welcome, and please proceed.
Thank you. I'm Samuel Carradine. I'm the Executive Director, as you stated, of the National Association of Minority Contractors. NAMC, as we are called, is a full-service minority business trade association representing over 3,500 minority contractors, subcontractors, and construction managers. NAMC is certainly heartened by President Clinton's intent to reform the healthcare system in the United States because so many of our constituents have either inadequate healthcare coverage, health insurance that is far too costly, or no health insurance at all. On the other hand, we're concerned as to the direction that these reforms take with respect to small business in general and the small minority construction business in particular. Ours is a highly transient workforce, and reform options such as employer-mandated coverage are especially problematic in terms of implementation, equity, and costs. Most of our membership are small construction businesses employing fewer than 10 employees, and our estimate is that less than half of these employers provide any form of health insurance to their workers. Furthermore, over the past 5 years, the construction industry has been disproportionately hit by the recession, and only now there are fledgling signs of recovery, making it even more difficult for those employers who are providing health insurance to continue to do so at the same level of support. In addition, the nature of the construction industry demands mobility of workers from site to site and often from employer to employer, based on who wins certain bids for work and where that work is located. While work may be seasonal or workers may change employers frequently, the need for health insurance is year-round, and the costs of employers either continuing to cover their workers in periods of downtime or having to frequently cancel and reinstate workers would be financially disastrous, not to mention being an administrative nightmare of the first order. In short, the effective result of mandated coverage on our membership would be reduction in the number of employees, a quagmire of costly paperwork and red tape, and in many cases, closing of the businesses. NAMC supports the need for reform, but we also acknowledge that reduced cost and increased availability of health care are, with the present delivery system, essentially competing agenda. Fundamental changes in the way the healthcare industry operates should be at the core of any reform, and we are pleased that the task force is examining a variety of options to address these problems. In general, NAMC endorses the intent of the administration to reduce hospital, physician, and pharmaceutical costs, and to promote insurance underwriting and medical malpractice reform, and to establish a system that would increase competition among providers with the hopefully attendant result of reduced costs to the consumer. Yet regardless of these reforms and related cost savings, universal health coverage, however defined, will have a hefty price tag. To the extent the government subsidizes or otherwise supports a form of health coverage for all Americans, our membership, like every other taxpayer, will be impacted. But it is in the specifics of how such coverage will occur that concern us. Rather than employer-mandated coverage, NAMC supports the managed competition model promulgated by the administration and endorsed by a number of other small business groups. NAMC would like to see individually mandated coverage which removes the burden from the employer and requires each individual to obtain coverage, with provisions being made for graduated subsidies based on the income, as well as provisions to cover the indigent and unemployed. This approach would also provide the kind of portability of coverage that is particularly necessary given the seasonal and extreme mobility factors inherent in the construction industry. NAMC supports the following cost containment reforms: elimination of state barriers to managed care, elimination of costly state mandates, raising the tax deduction for health coverage from 25% to 100%, reforming the medical malpractice system, and increasing consumer awareness so as to control costs. We look forward to an extended dialogue with the Clinton administration and members of Congress on health care reform issues, and will continue to vigilantly promote our position on behalf of our membership. Thank you.
Well, we look forward to it also. Thank you very much. Our fourth presenter on this panel is Stephen Elmont, Vice President of the National Restaurant Association. Welcome.
My name is Stephen Elmont. I am the proprietor of Maribel, a 54-seat restaurant in Boston. I also serve as Vice President of the National Restaurant Association. Our industry is consumed and concerned about healthcare reform. For the past few years, restaurateurs have struggled with staggering inflation in healthcare premium costs, with cancellations, with denials of coverage, and now with the frightening prospect of mandates. We are not engaged in hyperbole when we say that mandated employer-provided coverage or higher payroll taxes to pay for health benefits would literally sound the death knell for many restaurants and discourage other restaurants from ever opening. Our research indicates that cost and administration are the major deterrents for restaurateurs who are considering buying health care plans for their employees, as well as those for continuing to provide plans. Since I know my time before you is very limited, I will focus on two areas. First, the unique nature of the food service industry and our workforce, and second, the specific reforms which we endorse. We know what they would mean: more available coverage for our employees. We urge you to take these into consideration as your task force deliberates. Food service differs from other industries in several important aspects. First, we are dominated by small business. 72% of all eating and drinking establishments have sales of less than $500,000 and an average workforce of less than 50 employees. Second, our profit margins are extremely thin. The pre-tax net income for an average table service restaurant ranges from 3 to 5%. And third, we are labor intensive. Our workforce looks much different than other workforces. Our average employee works 25 hours per week, and our turnover rate is 100 to 140% annually. Today, as the nation's largest retail employer, food service employs 9 million Americans. By the year 2005, that number will climb to 12 million. The combination of these characteristics means that we are labor-intensive costs. We are very susceptible to having no ability to absorb these costs. You have asked us to discuss the best ways to ensure that employees of small businesses get health care coverage. We believe the most essential element of health care reform is cost containment. We adamantly oppose employer mandates, price controls, and global budgets. Instead, we support many of the concepts upon which build the strengths of our free market system. Here are the reforms we urge you to adopt. 1, we support pooling systems that would help small businesses and uninsured individuals buy quality health insurance at affordable rates. 2, we support tax changes that give all businesses a full tax deduction for the cost of health insurance premiums, but limiting the employer tax deduction and the employee tax deduction for excessive health coverage. 3, we support reforms to the insurance market for small businesses so that small business owners and employees are guaranteed insurance coverage. 4, we support federal pre-exemption of costly state laws, such as those requiring even basic benefit plans to include non-essential care and those that put a damper on managed care programs. 5, we support reduction of paperwork by creating a uniform electronic claim system that guarantees timely payments and curtails fraud. And finally, we support reforms to medical malpractice laws. These recommendations are aimed at removing the barriers that prevent businesses from providing health insurance to our employees. Yet if legislation is adopted that mandates all employers provide health care coverage for their employees, it will result in disaster for the nation's food service operators, large and small. Thank you.
Thank you, Mr. Elmont. Our final presenter on this panel is Andra Bennett, Executive Director of the National Association of Private Enterprise. Welcome.
Good morning. Thanks for inviting me. My name is Andra Bennett, and I'm with the National Association of Private Enterprise, headquartered in Fort Worth, Texas. We represent the smallest of the small, those employers with 10 or fewer employees, the mom and pop shops of America. The largest impediment to health care coverage in that small business community is cost. If employers with fewer than 10 employees could afford to provide health insurance, most of them would. In considering the issue of cost, we believe that the Health Task Force should focus at 2 levels. First, investigate the effect of rising health insurance costs on the coverage of small business employees. And second, focus on whether any of your eventual proposals will add to the cost of doing business for small employers and what effect that added cost will have on small business growth. We urge the task force to consider tough cost containment measures, such as global budgeting, restraints on doctor and hospital fees, and malpractice reform. You might also consider caps on the tax deductions for so-called Cadillac coverage. We also urge you to review how to include the medical care portion of workers' compensation insurance into the cost containment mechanisms. In addition to these measures, we urge the task force to sensitize yourselves to the effect of your proposed actions on the cost of labor for small businesses. Because of their narrow profit margins, small businesses are under extreme pressure to keep labor costs down. Mandated benefits, changes in the insurance market which would increase premiums, or payroll tax increases would all result in an immediate labor cost increase. These have a chilling effect on a small business's ability to keep its doors open or even to hire and retain employees. If the task force recommends and Congress decides to mandate small businesses to provide health coverage without substantial assistance, it would clearly result in fewer jobs and fewer small businesses. A survey of our 50,000 members show that 87% oppose a government mandate. However, when we pose the question by saying that the government would provide substantial assistance along with the mandate, the number opposing it drops to 65%. This might point toward a possible compromise on that issue. Many small businesses already provide coverage to their employees, but we are worried that some of the proposed insurance market reforms will ultimately increase the cost of insurance for those already providing coverage by driving many insurers out of the market and by allowing people to purchase coverage only after becoming ill. The task force needs to ensure that any reforms to the insurance market are actuarially sound. If the task force decides that additional revenue are necessary to ensure coverage, please bear in mind that payroll taxes are the most regressive form of taxes because they tax labor and not profits or consumption. As they say, the power to tax is the power to kill, and payroll taxes kill employment. Finally, the National Association of Private Enterprise is a benefit association, and one of the benefits that we offer is health insurance. We want to continue to be able to offer our membership the choice of purchasing indemnity insurance through us. Thank you for listening.
Well, thank you very much. We'll have some questions now, and let me note that at the beginning of this panel, we were joined by Bob Rubin, who is chairman of President Clinton's National Economic Council. Let me note also a couple of facts about small business and health care. 70% of small businesses in our country now provide health insurance for their employees. And it seems evident, at least to me, correct me if I'm wrong, that 70% will always be at a competitive disadvantage unless the remaining 30% have some kind of health insurance also. So one question is how we avoid the current situation which penalizes those small businesses which take the extra step of insuring their employees. Secondly, it seems evident from your presentations that what small business needs more than anything else is to stop the explosion of health care costs and to end the uncertainty in the current insurance market. So if I could begin the questions by asking you to enumerate what you see as the essential insurance reforms that you feel are necessary and how these reforms should be accomplished.
Well, I'd like to begin by reiterating my testimony, and we've heard it from others on the panel. Cutting the cost of insurance is first and foremost. The company I cited in my testimony that does not provide health insurance for its 6 drivers, when it recruits new drivers, has to find drivers whose spouses have health insurance and are covered. Now that's a fairly delimiting population and a shrinking one. We would argue that if the cost could be cut to this company, if the workman's comp cost, for example, could be reduced from $27,000 a year down to $18,000, that company would welcome the opportunity to provide health insurance, because most of the employers of small business support health care insurance as a fundamental right.
So the one insurance reform you're singling out is just to control the cost. Anyone else? Yes, Ms. Smith?
If I might add that cost containment certainly is very important, and one way to achieve that would be through healthcare purchasing cooperatives where large pools of people from different segments, the payers, the insurers, the healthcare providers, get together and they have a negotiated set rate, and in particular a cap on the future increase. What small businesses often have happen to them is that when they purchase insurance, the first year everything looks great, and then their experience rating seems to be too high for the insurance carriers, and then they are either dropped or they see their costs escalate as much as 30% and 40% in the case of people who have talked to me. I think the second main problem that we're looking at is access. And I can't tell you how many employers that I know who frankly carry insurance for their employees, but because of pre-existing conditions or the age of employees, they are not able to carry universal coverage for every employee in their company or frankly for themselves. So I think that having, I know that having access for everyone is going to be critical to making the health care system in this country work, in addition to cost containment, which we believe can be done through competitive in the free market system, as long as people are brought together in these cooperatives and have to negotiate a contract.
Vice President, I wanted to comment quickly about the 70% that you mentioned of small businesses that do have health insurance for their employees. I would suggest that the definition of small business is fairly broad, and that you'll find that those that do not have it are skewed to the smaller of the smallest small businesses. So they are generally not competing with those middle-sized businesses that are able, because of economies of scale and other reasons, to offer that. So I'm not certain that that competition is as direct as you suggest. I would like to emphasize the point of portability, because that's particularly inherent in our construction industry. We have workers moving all over the place, and they move from employer to employer and from state to state and location to location, and it's very important that anything you consider be able to accommodate that. We suggest the individually mandated insurance, but whatever direction it goes, it should emphasize the fact that these employees will be getting health care in different states in a given year. They may not build the same kind of relationships with physicians and with HMOs that have been suggested, and something has to be done to accommodate that type of approach. I'd also like to emphasize what my colleague said about the associations. In our industry, a number of the trade associations, not ours yet, but we hope to, offer health care and other types of insurance. So we would like for any direction that is taken to still allow us to continue to offer those types of services.
Implied in your question about the 70%, 30% assumes that 100% of the people want insurance and that all businesses want to offer it. One of the things that we found in our society is that cafeteria plans of benefits say that some people do want certain benefits, other people do not want certain benefits. I do not believe it's a disadvantage for people not to have insurance in your 70, 30% model, because in my business we do offer group insurance to all of our employees, and only 40% have decided to take it.
Well,
it's because of cost.
Yeah, well, of course, but I wasn't saying that it's a disadvantage not to offer insurance. If you have two businesses in direct competition with each other, and the price built into the products they're selling has to reflect market conditions, and yet Company A takes the extra step of providing health insurance for its employees, and Company B does not, then Company B can, by cutting that corner, get an advantage in the marketplace and over time drive its competitor, Company A, into bankruptcy. Now,
I disagree.
Well, if the cost of providing health insurance to employees is the fastest growing cost that many businesses have, then obviously it is a burden on some businesses that provide such health insurance for their employees to compete with others who do not. Do you disagree with that?
No.
Well, that's the point I'm making, and I can tell you from experience in Tennessee that there are lots of small business owners who have provided health insurance for their employees for years, sometimes for 2 or 3 successive generations, and who have now, in conversations with me, said they're faced with this awful dilemma of either going out of business or canceling the health insurance that they've had on their employees for so long. And they are anguished about it because they know how important the health insurance is to their employees. So, you know, I hear from lots of business owners about this, and surely you do too.
But the 70% that are having it and that are struggling to maintain profitability, the 30% that would be imposed to have it would probably go into bankruptcy. If those are marginal businesses that can't afford it, by mandating the 30% to have it doesn't put the other people at an equal playing field. Some people just may be smarter managers and be able to fiscally understand how to manage their business better. Mandates really are oppressive for small businesses who aren't smart enough and fast enough to do it. I mean, employers with over 100 employees in America, I believe over 90% of all employers with 100 employees have insurance.
Now, did you say that a lot of employees just don't want health insurance? Is that what you said
They
earlier?
either don't want it or can't afford it. I was shocked.
Oh, well, no, wait a second. There's a big difference between those two statements. Do you know of a lot of employees who just don't want health insurance?
Certainly. Most of the younger people in America think they're not vulnerable to disease or illness. If you were to ask people that probably the ages of 20 to 25 or 20 to 30 think that they're made of steel and don't think they need it. That's not smart management, Mr. Vice President.
The polls,
I'm not talking about that at all.
The public opinion polls that I've seen, and also the communications that we've had with working men and women all over this country, indicate that, quite to the contrary, most all employees of businesses in this country would like to get health insurance and protect themselves and their families. Now, I don't want to push you into a corner and have you saying something you're really not saying. You want to argue over mandates. That's
that's right.
That's really what you want to talk about. But I want to talk about a step preceding to the solution to it. I want to talk about what the challenge really is. People can't afford health insurance, and they want health insurance. Now, and to fight some battle by making the argument that employees of businesses, in many cases, just don't want health insurance, doesn't seem to me to be on the mark. I don't mean to offend, but I think most people do want health insurance.
It has to do with trade-offs with cost again. The statistics say that if they have to pay more than, I believe it's $200, there's about 80% of Americans that don't want health insurance if they have to pay for it.
Well, of course, and that's why cost control, and that's why measures to reduce the unnecessary expense represents such an important part of this overall reform. I want to recognize my colleagues here, but I want to ask one other question just very briefly, and you don't need to answer because maybe it's a rhetorical question. But one of the reasons this problem has been neglected for so long, and one of the reasons we haven't had national health care reform, is that we haven't been able in this nation to find an approach that everyone agrees with 100%. Is it the position of the organizations on this panel that you will oppose any plan that you don't agree with 100%, or could you support a plan that has maybe one or two elements that are not pleasing to you? What's the answer to that question?
I think we all said very similar things, that we wanted malpractice reform, that we wanted redundant state benefits to be superseded by the federal government. I think we said that we wanted tax changes so that core coverage was tax deductible for employee and employer. I think there's a lot of agreement here.
So there's a willingness to compromise and maybe accept some things that aren't 100% to your liking.
Well, we call it shared responsibility.
Right.
Okay, very, very good. Secretary Shalala?
Just a quick question. If you're opposed to employee mandates, do you favor a consumption tax? I mean, how would you pay for this system?
Employer.
I assume that that all of you are opposed to any kind of mandates on employers.
Employer.
Do you favor an alternative scheme like a consumption tax?
Well, I suggested that what we call an individual mandate may be the appropriate way to go. And I was pleased to see in this morning's Washington Post, in fact, that the administration is looking in that direction, where the individual employee is the holder of the insurance and carries that with him or her to whichever employer they go to. Now, in terms of how that's paid for, understandably, there may be some cost sharings between employee, employer, and government in the form of various kinds of subsidies, but then I would think for the employer, particularly the small business employer, there may be some trade-offs on the tax side.
How would you mandate individual coverage for part-time employees?
I can give a suggestion here. One way is that every individual in this country must have insurance, and the way in which, some of the ways that we could have that happen would be, for instance, when you register for a driver's license or you file your tax returns, you have some kind of a checkoff system that says what health care system you're in, and I'm thinking of healthcare purchasing cooperatives. So if it's temporary workers, they have insurance, and it's carried with them from job to job. They are put into a healthcare cooperative, basically. So that's one way where we could be certain that every individual in this country has health care.
Can I return to the question of financing just for a second? Even if the employee carries the insurance with them, there is still the question that right now we primarily finance health care in the country by employer premiums. And if we are going to add a number of people who are now uninsured but employed, there's the question of how you pay for them. And in what some of you suggested, you were saying, well, the employee would be responsible, but the government in some way would help lower income employees. And that means the government still has to raise the money under that framework. So what I'm suggesting is if the employer is not going to be contributing under a mandate, how would you favor financing then what the government has to raise?
I was under the impression that only 29% of the total insurance cost or the health care cost was paid for by business.
There's somewhat over $300 billion. So if we, for example, took business out of it completely, we'd have to find a way to raise $300+ billion. And so I'm just asking for suggestions.
I mean, one of the things is that people should pay for their coverage. I think if Americans were to participate in the healthcare process, in all probability, were there to be a stake in it, that the cost would go down. Because as people pay for things, services they use, they get more sensitive to how they're spending the money.
But in what you suggested as well, you indicated that certain Americans might not be able to afford that.
That's correct.
Certainly at the prices today, and even if the prices were to come down, it would be a while before most Americans could afford to pay $3,000, $4,000, $5,000 a year for coverage. So the question is, how would you finance those people who could not afford that? And you suggested something about government subsidies, but then we've got to raise the money for those government subsidies, so I'm just wondering where that comes from.
I think to the extent that the government is going to be involved in providing or requiring that universal health coverage be present, it's going to cost more than any suggested scheme of raising money through employer or other means has been put on the table. It's going to mean more taxes, and however you cut it, it's going to hit all Americans across the board, and we as employers would be paying our fair share as American taxpayers. I don't know, I think the debate is going to be over how big that number is, but I don't think anyone is foolish enough to think that the result of this exercise is going to be provision of health care universally without some increased costs at the government level that will be passed on to the taxpayer. So that's one direction. The other direction, I'm also not suggesting that employers get out of the business of assisting their employees in terms of coverage. However, there are a variety of ways. There's shared, it could be in the form of increased salaries to, in turn, if you have better job security and better business, we can pay our employees more money. And particularly in the construction industry, we can begin employing longer periods of time and not having so much downtime and so much paperwork, et cetera. So I don't have a precise answer, but that's the direction of covering it, as opposed to mandating it, because that doesn't address the problem at all.
If I could interject a brief point, Ms. Smith, before you go. Mr. Carradine, actually, some of us are suggesting that it is possible to provide better health care coverage at less than the total cost that our nation is paying today. Because if you look at the figures, we in America are now paying 30% more per person for health care than the people of any other nation on the face of this earth. It now represents 14% of our gross national product, or gross domestic product, and only one other country approaches 10%. We are at an enormous competitive disadvantage, and all of the studies show that as much as 25 to 30%, Ira, you can correct me if any of these numbers are wrong, as much as 25 to 30% may be wasted on completely unnecessary care, sometimes counterproductive procedures, in large part because the system we have for health care now encourages waste and drives providers toward procedures that are not always geared to the best medical outcomes. So we really believe by making some sense out of this system and sorting the responsibilities out in a better way, we can save money for Americans. Now, who pays and how it is allocated, those are very difficult questions, and it is perhaps to that point that you were really speaking, but I didn't want to leave on the table.
Well, I don't disagree with that. I think there can be great savings, but I'm suggesting that however much you can save, if you apply that entire amount to the universality issue, I don't think you're still going to cover the total cost.
Ms. Smith.
Well, while we hate to use the dreaded T word for tax, you know, that is really what we're talking about. Revenues can be raised in many different ways. Just one or two that come to my mind quickly are persons who have two insurance policies, where we now are in the two-income families, and both people are being covered by their employer, so they end up, frankly, it does encourage waste in the system because they figure that they're covered 100%. Well, if we had some kind of tax on excess benefits, that would be a revenue raiser there. So everyone is entitled to the basic system, and those who choose to have more than the basic system or choose to have double coverage then are taxed in some way. That is a way to raise the revenue to help offset the cost for helping those who will find it a financial burden to carry their insurance.
Mr. Almont, one of your 6 key reforms was talking about the issue of getting rid of excess paperwork, and you talked about electronic billing or claims systems. And I'd really like to hear some of you speak to that particular system in terms of small business.
Well, I can speak for 2 ways, not only small business, but I'm a trustee of 2 major teaching hospitals, and both on my side as well as the hospital side, paperwork is really bogging down the system and making it very, very uncomfortable for everybody to do what they have to do in order to get paid. So any sort of the use of a database system that's going to make it more efficient for employees, employers, and then the healthcare providers, I believe is going to help bring in that $300 million that Mr. Magazzino was talking about. $300 billion, sorry. So,
Mr. Rubin?
This may be to some extent, or maybe more than some extent, returning to something that's already been discussed, but there obviously has to be government revenue to deal with the health care issue, and whether, as the Vice President suggested, the savings will be at least adequate to cover universal access or not, I guess remains to be seen. But it leads me to 2 questions. When you look at all the various possible ways for the government to get that revenue, employer mandates or a VAT or whatever else you might think of, which strikes you as least troubling with respect to the competitiveness and effectiveness and viability of small business? In other words, if you take as a given that there has to be an amount of revenue raised from the system that's equivalent to what it is today, which may or may not turn out to be correct, but if you take that as a given, which is the way that least troubles you in terms of the viability of small business?
Income tax.
What?
Income tax.
Income tax?
Right.
In other words, increased income tax rates.
That crosses all lines. It doesn't single out small business, big business. That's what we're concerned about, is singling out small businesses that are most vulnerable to trying to raise prices to cover these costs.
Do the others of you agree with that?
Our members have told us that they would prefer to see the reforms made first before any taxes are levied.
You mean the cost-cutting reforms?
Yes, in the litigiousness of this society, they would be willing to consider alternative dispute mechanisms, for instance, in the workers' comp system, and those kind of things.
Well, let's agree that whatever is done, there'll be I don't know about maximal, but a very substantial effort to reduce costs. So I was granting you that. But I was saying with universal access, let's assume that at least you have to maintain what you're taking in now, although as the Vice President suggested, that may not turn out to be the case if the cost cutting is effective enough. Which tax would you then think is least inimical to small business, least harmful to small business? Which mode of raising the revenue?
Probably agree with Mr. Elmont.
On the income tax? That's the second question?
If I might make a comment about the administrative costs, I was struck by a conversation I had on the plane here with a young couple from IBM who happened to be familiar with the subject, and the young woman told me that it only costs IBM 1% to administer their insurance plan, and I know the statistics for small businesses that it costs us 29% to administer the cost. So when we go back to the comment of how to do electronic billing, etc., it's really going to be critical for us to move into the technology that's available to us now. I think that's going to be a major cost-cutting effort. In terms of your question, I was struck by the congressman who said, I only pay $99 for insurance a month, and really I probably should pay $500 a month. So I think a revenue raiser is perhaps for all of us to look across the board at evening out the cost to us, and actually that may raise funds if those who are able to are paying their fair share.
I'm interested in the question of purchasing cooperatives, which you've all mentioned, and which for small business can hold a particular attraction for many small businesses because it's a way to cut the administrative costs that they have and allow them to pool together. Do you have any feelings about whether there ought to be mandates that companies below a certain size go into a purchasing cooperative in order to give it a big enough base? Or do you think there should not be such mandates? And if you do think there should be, at what size would you make the cutoff and so on? How would you form the purchasing cooperatives?
One idea, we would, SBLC, I believe, would support qualifiedly mandates if there were variations in size in terms, but it seems that the small businesses of 25 employees or less are the ones that are most critically affected by these healthcare costs, and maybe that would be the starting point. If that's the group of small businesses that has the highest number of job-creating opportunities for Americans, why couldn't we focus on that group initially and find some kind of way of at least providing a basic health insurance program, mandated?
We, of course, strongly oppose mandates, but with regard to your insurance pools, it seems to me if those insurance pools were regional, anybody with a federal tax ID number should be allowed to go into the insurance pools.
Would you allow individuals to make the choice of whether they purchase through the insurance pool, or would they have to go only if their company went? Well, those of you who favored individual mandates, in other words, suppose a company offers its own plan, but the individual working for that company says, I'd rather go through the purchasing cooperative. Would you allow them to do that?
As entrepreneurs, I think that free choice is really what we're all about. So I believe that giving the individual the choice is really important here. And there's little to be lost by giving the individual the choice, whether the employer pays it or the individual goes into the purchasing cooperative. I think it all evens itself out.
How do you feel, oh, I'm sorry, had you finished that? Yeah. One of you commented in your testimony, it may have been Mr. Petty, about the short term and the question of whether or not it is advisable societally to have cost controls on healthcare providers, cost and volume controls, but anything, some kind of controls that affect cost and volume, and there's an effort to get costs under control very quickly. I think it was you, wasn't it, Mr. Petty? Yes. Would anyone like to comment on that?
I think small business could be, as an entity in the American free market, could be defined as one that cannot pass its cost on to the customer. And what we find in the moving and storage business is every year the ability to pass costs on is reduced significantly. So in the case example I gave for that little company in Des Moines, Iowa, paying $27,000 a year in workman's compensation. If you could bring that workman's comp cost down, now this is a company that hasn't had a claim, by the way, in 3 years, and the costs are going up each year, there's nowhere to go. if you could bring that, if you could create a program that would take basic health care coverage that would ordinarily be handled through workman's compensation, and leave the workman's compensation claims for the more exotic or extreme cases, and take the basics up. Because in our industry, unlike you know, waiting on tables and picking up used dishes, picking up good things in the moving and storage business is a risk every day. So we not only need the insurance, but we have to protect ourselves against exorbitant workman's comp.
You clearly haven't picked up a large tray of dishes recently.
Oh, yes, I have.
Do others of you have reactions to the notion of cost
I have a
controls?
reaction in that there's a problem with our system is that there's no accountability on either side. Both the users, the employees, Americans in general, and the people that are providing. It's a one-way system, and it seems to me that anything that we do to make both parties mutually accountable for the cost, for the containment, for the amount of money out of their pocket, the better we're going to be. In the workers' compensation program in America right now, it's bankrupt everywhere in the country because there is no accountability. And I think if we were to do it with mandated health insurance, I think we would end up with the same sort of thing. We have to have accountability for people who use the system as well as people who provide the system.
But your people are paying workman's compensation insurance already, correct?
Yeah, I was making an analogy where workers' comp is there is no accountability. The employee.
Well, I know that.
That's what I'm talking about. So
no, but go ahead and finish your point.
Well, my point is that you're paying workman's comp insurance premiums anyway. All of your, for your employee. All right. I wouldn't want the panel to have the impression that small businesses oppose flat out to mandates. That's not my testimony, at least.
Well, we are.
I think that if you were, well, all right. I think that if you cut the workman's compensation premium, wouldn't your insurance company members of your association want to provide health insurance at least at a basic level if it didn't increase the overall cost of what you have now?
The concept of mandates is un-American. The concept of mandates of anything, we're in a free enterprise system where if one employer wants to do one thing that he or she feels is going to benefit either their customer and or their employees, they're going to do it. If another employer may look at them with a jaundiced eye and say, that's not going to improve my bottom line. So that we all sitting here are successful because we make decisions every single day on what's going to improve the customer experience, what's going to improve the employee experience. And so we oppose mandates for that reason. We also have a very severe problem where 6.5 million employees work under 25 hours a week with 100 to 140% turnover annually in our industry, not because we're not a good industry to work in, but I'm sure some of the members in the panel have worked in our industry to get yourself through college. I mean, it's a transitional workforce done because we offer alternatives. And so we're really paranoid as being kind when we say if we had mandates for employers over all of our workforce. I mean, we would be in serious, serious trouble.
Do you have inspection of your food preparation facilities and your sanitation and health standards and so forth?
Of course.
In your restaurant?
By me or by the state or by the city? Which?
Well, you open up and go through that process, correct?
Correct.
Is that voluntary?
No.
Is it mandated?
Yes.
Does it make sense?
Does it make sense? I think it makes sense, but there aren't enough resources to do a good job, so we employ our own inspection agency. Would you describe it as un-American because it's mandated? No. That's protecting the consumer.
Well, the point I'm making is that some things, when applied universally, make sense, even if they're mandated, such as the inspection I'm talking about. You get a benefit from having this mandated health inspection because you don't have to compete with some other restaurant that cuts corners and doesn't provide the minimal standards, and your entire industry gets a reputation with the public of being safe. And you don't have to run the extra risk of some bad actor in your industry cutting corners so much that it gives the whole industry a black eye. So all that's a benefit to your industry from that mandated approach, isn't it?
If you want to talk about wellness in that way as compared to catastrophic illness, yes.
Well, would you talk about Social Security that way? I mean, Social Security clearly is a mandate for the public good. Is there something fundamentally different between Social Security and health benefits?
It's because if I give an inch, I am terribly, terribly concerned about the cost of that inch. And that's why I am so paranoid in talking about mandate versus not mandate. Obviously, I'm an employer who provides insurance because I believe it's to my interest and my employees' interest and my customers' interest. I also have a smoke-free restaurant. But if you were to legislate that I shouldn't have a smoke-free restaurant, I should have a smoke-free restaurant, I would probably have some smoking seats. Because I want to do what's best for my customers. And I want to do what's most cost-effective. I am paranoid about $3,000 to $5,000 a year in insurance premiums for mandated health care costs for the nation's largest retail employer. Paranoid. We can't absorb those costs. So that's why I can't give an inch, because I don't know what kind of inch I'm talking about. It's scary.
Could I go back again to the question of how you pay for this? Assuming for the moment that there were no mandates and that the cost of this was absorbed, the insurance was with the individual in some way or other, and the cost was paid for in some other way, you all would then benefit from the fact that you now pay insurance for medical benefits and you wouldn't have to pay that anymore, so you've had a windfall. My question is, if you're going to have to pay the same amount of money for a profitable small business, no matter how it's structured, forget for the moment what form this would take, but if you would have to pay the same amount of money for a small business, no matter how it's structured, which is the way that would interfere least with your ability to function and be competitive? In other words, it could be an income. It's a little bit like my question before, but it's a shade different, because I'm saying you're not going to reduce your costs at all. But if you had an income tax, for example, you'd only pay it when you were profitable, so in bad years you wouldn't have to worry about it. If you had a mandate, you'd pay it no matter what way. If it was a VAT, then I suppose you're not paying it, but it's a higher cost of your product, so maybe you have more difficulty selling it or something. I don't know. I'm trying to get, what I'm trying to do is say, assume you can't get away from paying the cost, what is the way that least interferes with the functioning of small business?
I think that global budgeting is at least interferes on a
daily
daily
basis. Yeah, but you keep
basis.
wanting to save cost, which is fair enough, and all of us do, but I'm suggesting that, I'm saying let's assume for the moment that that doesn't get us what we need for universal access and so forth. Sure, all of us would like to solve this problem as much as possible by saving costs.
Well, the bottom line is going to be to have as many individuals as possible participating in absorbing the cost. And so that's going to be income tax, most probably, income tax on excess benefits. I mean, we can go back through this. Also, if we have cost containment, then we're talking about over a very short period of years, probably 3 to 5 years, bringing these costs into line where the shared responsibility becomes less and less. And if I can go back to your other question, I believe what you were asking about was basically price controls and would we...
In the short run,
right,
until managed competition took effect.
And again, as entrepreneurs, historically, we haven't seen price controls work in this country. So I think that this is one lesson we can learn from the past. We do know that there is a way to have managed competition, and through these healthcare cooperatives and through contract negotiations, which are entered into by all parties. So we believe that is the answer.
Let me just, a follow-up question, if I may. How would you feel if there was a cost control system that, unlike the past, actually led into a program that looked like it would be effective? In other words, I think the argument's been made in the past, you have price controls that bottles up demand, and then they're eliminated.
Spirals
and
in the end,
yeah.
Right.
Here you might have it geared into a long-term program so that the long-term program would take over from the price control period. Would that make, if you could be persuaded that that would work, would you then have a different view on price controls?
It's possible. What we need to do is to see the details of a plan like that and to really apply it then to real-life businesses and individuals who are out there. So I think that we're open to many possibilities. What we do share is that one of the possibilities, that is employer mandates, is the one that we find most burdensome and onerous.
You tend to seem to be against that.
Mr. Elmont, do you want to get back into this?
There's also something, the thrust of the panel's questions, which I find a little troublesome. I was under the impression that we weren't talking about entitlement, that Americans were concerned about availability. And some of your questions, sir, talks more about entitlement. I think if Americans had availability to purchase the product, we could then worry about entitlement. But there isn't an availability of the product right now.
Well, but there's the question of, there are a number of questions that raises, at least one of which is, what about those who can't afford to purchase the product?
They first have to have the availability of the product to even purchase. If you are a single person or a family unemployed, meaning you could be rich, there still may be no availability of product for you regardless of your income level. So there's no availability of product in the system right now. That's really one of the major problems that we face. I mean, I'm extremely wealthy. I sold my company, I retired, I did not have group insurance. I could not purchase group insurance. I started a company started a restaurant and a business in order to have group insurance. That is sad. That is very, very sad.
It seems like, and having run two small businesses myself, I'm very sympathetic to what you say, and we had to face the same situation that as a small business we were paying considerably higher rates than larger businesses for whom we worked for no reason other than the fact that we were small, and that's the way the market works. So I'm very sympathetic to that. My question, though, in talking about insurance reforms, which I think you've all expressed support for, that would address the kind of availability issue, and the purchasing cooperatives, which would begin to address the particular problems of small companies and their cost. I think you're all agreed on that. But I'd like to hone in again on the question that Bob Rubin was beginning to ask. In your testimonies, a couple of you, I think Ms. Bennett and Mr. Petty, talked a little bit about a necessity to get costs under control quickly and transition perhaps into some type of budgeted system. Some of the others of you were not so sure about that as a way to go. I had the sense that you probably agreed on what it ought to look like 5 years from now, but that you might have disagreed on what you've got to do the next couple of years to get us there. And I'd like to ask you to amplify a little bit on those next couple of years.
I'd just like to say, I think that the focus, most of the conversation has been on how we pay for the service, but not a lot of it has been on how we cut costs.
That's what I'm really asking, is how do we get costs cut?
I just would like to emphasize that I think a lot of the savings can come. I don't think it'll be all, but I do think that there are ways to cut costs. We've all experienced war stories of going to hospitals and getting a bill of X amount for the hangnail or the sprained wrist or something like that, where three physicians had to look at my son for sprained wrists in basketball and wound up costing like $500 some to get the thing taped up. That's ridiculous. And so I just think a lot of focus and energy needs to be put into the cost containment side. You're going to get a lot of pressure against that, clearly, from those industries, but I think that's a major, major, major problem.
We agree with that, and I guess what I'm wondering, though, is how you would do it in the short term. In other words, in the longer term, I think you've all expressed some support for a managed competition type approach and so on, but in the shorter term, how do we try to get costs under control? Is there a way to do it?
Tort reform is one of those. Obviously, medical malpractice and tort reform in general is going to help reduce costs. The other thing is having employees or the users participate in that process. If he didn't have to spend $500, if some of that money came out of his pocket, there may have been some accountability and say to the doctor, listen, that was not good value. I'm not going to pay it. But there's no accountability in the current process in America. So bring some accountability into the system, some malpractice reform. I have a feeling that our prices will go down.
How about shutting off the X-ray machines for 90 days? I mean, if you look at most injuries or contacts that a patient has with the healthcare system, before you get to page 2 of filling out the forms, they want you to be X-rayed. And I had a recent experience right here in Fairfax, where a daughter went to the hospital that was hit with a basketball in her throat, and in the emergency room, they immediately ordered an X-ray. And I said to finally the head doctor came in. I said, I don't think that you need an X-ray. He said, I agree with you. Now,
what had happened to her?
She was hit with a basketball and the Adam's apple and started hyperventilating. School nurse panicked and called Fairfax Hospital Emergency. 3 people came in an emergency vehicle to the school and inspected her, decided they couldn't do anything because the doctor requires anybody who has an air passage injury must go to the emergency room. So we all pack up and go to Fairfax Hospital Emergency Room, whereupon the first doctor comes in contact, orders an X-ray. And 10 minutes later, the head doctor came in and reversed it on my insistence. Now, that's just a little case in point. But that was $129 off the bill.
Yeah. I had almost the identical experience a couple of years ago. One of our daughters was playing with a pillow, and accidentally the pillow ripped a little bit, and she accidentally breathed in a feather and had an air passage obstruction. And of course, we panicked for what seemed like an eternity until she cleared her air passage and started breathing again. And as much to reassure myself as anything else, I suppose, I took her down to the community hospital near us and went to the emergency room. And before they would agree to go through with everything, I had to sign a consent form for an X-ray. And I refused to do it and asked if a feather was still lodged in her windpipe somewhere, would the feather show up on an X-ray? And they said, no, it would not. And I said, well, why then do you want to do an X-ray? And they said, well, it's a procedure. Well, last I checked, and there are folks here who probably have better information or up-to-date information. Last I checked, our nation was spending something like $2 billion per year on that single item, unnecessary pre-admission X-rays. Now, that's ridiculous and is a clear example of the kind of unnecessary expense that we need to eliminate.
Which we could possibly cover also with these practice norms and what would be required. I mean, that is another way for us to look at cost containment. And also through these purchasing councils, they could be put into effect immediately. They're not 3 years out. They can be put into effect within months of passage of some type of bill because the models are already out there running successfully. So it's just a matter of building on that. And we probably all have a war story about the hospitals, and I have one of my own, which is being in for some surgery and having my blood taken every single day and finally rebelling and saying, why are you doing this? And being told by the technician, every patient in that hospital, which was Stanford Hospital, major hospital, every day had their blood drawn. I mean, it's an incredible cost. Yeah. And when I refused, I'm sure I got the black mark problem patient on my form, but that is something, and frankly, I think that we will get cooperation in holding down those costs from the medical community as well.
Well, let me repeat something I said at the outset of our forum today. Any additional thoughts you wish to share with the task force, please feel free to elaborate your views in a written statement. And I mentioned earlier that the NFIB had been invited to attend and had declined. They are also invited to submit a written statement if they care to. I'd like to thank all of you for participating in this panel. We will have another business panel later in the day oriented a little bit more toward larger businesses, but you have helped us to investigate the best way to ensure that employees of small businesses get health coverage, and we are very grateful to you for being here today. Thank you very much, and we look forward to continuing to work with you. Let me invite our next panel here. I'll say to my colleagues here that we'll have a transition while they're coming to the witness table if anybody needs to take a short break, but I'm going to go ahead and introduce them by name and set up the next panel. We're going to ask this panel to address the following question. Given the need to control costs how can we ensure that people in underserved areas have access to quality care? Our panelists will be Larry Nackey, Executive Director of the National Association of Counties, Robert McAlpine, Director of Policy and Government Relations for the National Urban League, Nancy Danielson, Legislative Representative of the National Farmers Union, Raul Yazagira, President of the National Council of La Raza, and Michael Anderson, Executive Director of the National Congress of American Indians. We're very pleased that all of you could join us here today. This panel is going to be focusing especially on the underserved. We're going to hear from several groups representing underserved populations, and our first witness will be Larry Nackey. As I already indicated, he is Executive Director of the National Association of Counties. Mr. Nackey, welcome, and please proceed.
Thank you very much. Mr. Vice President, members of the task force, good morning. My name is Larry Nack. I'm the Executive Director.
I apologize for mispronouncing your name. Larry Nack?
Nack, rhymes with lake. Excuse me. It's a name that invites mispronunciation. I'm the Executive Director of the National Association of Counties, which represents over 3,000 counties throughout the United States and 48 states. I'm a resident of Montgomery County, Maryland. It's a pleasure to be here this morning. Since I noticed the green light's going, I will speak quickly and keep you on schedule. Let me summarize my statement and background materials by briefly describing the county role in today's healthcare system and trying to offer 4 suggestions that we believe will help ensure access to quality healthcare and also help control costs, the questions that you have asked us to address today. The county role in healthcare is a unique and comprehensive one. Counties are the healthcare providers of last resort to the uninsured and the underserved in many of our communities throughout the nation. They also provide frontline preventive services and primary care services to the community at large through some 3,000 public health departments in most of the counties of our nation. A few facts will illustrate our commitment to the uninsured and the underserved. First, counties spend over $30 billion a year on health care. Counties are the providers of last resort in 36 states and serve most of the 37 to 40 million people who have no insurance, the ones that we so often talk about. Counties own and operate some 4,500 health facilities, including 581 hospitals in this country. And counties pay a portion of Medicaid in over 20 states. Just an aside, you should also perhaps be interested to know that counties through their hospitals train over 1/4 of the doctors in this country at this time. Given this comprehensive role in preventive and primary care services, inpatient care, and long-term care, we have a number of suggestions that we believe will help ensure access to quality care and help control costs. First, we recommend that a specific percentage of total health care expenditures be set aside for those traditional public health programs such as environmental health, food and water safety, disease prevention and control, and health education. These are the programs that are the preventive community-based programs that we think are so necessary to help ensure a healthier population. Nobody else provides these preventive community-wide services. Nobody reaches out to the underserved as these programs and services do. We believe that this upfront investment will help control costs now and in the future as we go down the road with a reform system. Second, we recommend that under a reform system, county primary care health programs through public health departments be eligible for the same funding available to federally funded entities such as community health centers. The infrastructure and delivery system for primary care services exists today through these 3,000 county public health departments, and we urge you to use it, and we urge you to believe that it will save you money and improve access in the short and long run. Third, we recommend that a reform system recognize the need to provide and integrate support services, such as child care and transportation, with the physical and mental health services that we are talking about providing. got to recognize the county's existing role in providing those support services and integrate them into any new system. And finally, we recommend that large counties or groups of counties be eligible to be designated as HIPICs or AHPs, and that county officials be included on national and state governing boards. So staying within the time period, these are a few of our suggestions. We have many other recommendations that have been submitted to you today and are part of the testimony, and we thank you very much for the opportunity to appear.
Thank you very much. Our second presenter on this panel is Robert McAlpine, Director of Policy and Governmental Relations for the National Urban League. We're delighted you're here. Please proceed.
Thank you, Mr. Vice President and distinguished members of the task force. Let me move very quickly. Partner with community-based organizations and community-based health centers to deliver health services. Such partnerships will assure the delivery of health care in familiar and trusted surroundings, reduce the impact of extraneous barriers such as transportation and child care. Home service by health professionals, paraprofessionals should be considered for some illness. The health system must consider the input from both the consumer and provider with regards to planning and evaluation and promoting family-oriented community-based health care. A health education program with targeted African Americans and a range of illness must be critical among this group, should be developed and delivered in a cultural competent manner. Such messages should consider beliefs and attitudes of African Americans toward health care. There is a critical need to reinforce the behavior of providers to ensure that health care services are user-friendly. Often those seeking health care do not return because of the manner in which they are treated. Prevention programs aimed at substance abuse, AIDS, infant mortality, homicide, cancer, teenage pregnancy, and hypertension should be expanded. This would greatly reduce the need for more costly treatment and services. The training of minority healthcare professionals is essential to increase the number of qualified persons who would render care to the minority population of our communities. African Americans are currently underrepresented in the health professional. African American medical schools should receive the necessary funding to allow them to maintain high quality of medical instructions. A healthcare system should be developed which is accountable to the public, monitored by social, state, and local governments, affordable and easy access, one that assures primary care, geographic and cultural distribution of providers. The program should foster consumer and providers' accountabilities with respect to users and the abuse of health care resources. Insurance companies should be required to offer coverage to high-risk consumers at non-discriminatory rate. This would overcome the problem of fee-for-service coverage by encouraging the growth of health maintenance organizations. HMOs should include a mixed panel of competent doctors whose primary goals are to ensure the delivery of quality health services to all patients regardless of race and economic standards. A shift of emphasis from treatment to prevention must be rewarded. Thank you, Mr. Vice President.
Thank you very much. Appreciate it. Our third presenter will be Nancy Danielson, Legislative Representative for the National Farmers Union. Welcome.
Good morning, Mr. Vice President, panel members. My name is Nancy Danielson. I work in the Washington, D.C. office of the National Farmers Union. I represent 250,000 farm families, and I am a lifelong member of the Farmers Union. And like Secretary Shalala, I lived in Wisconsin before I came out to Washington. To put it very simply, farmers cannot afford not to have health insurance because they risk losing their entire farm. And yet the cost has become so high that this is one of the #1 issues anytime we go out to a farm meeting. Our principles are universal coverage, which has been a priority for us since 1938, affordability, cap on the cost, choice of doctor and hospital, access in rural areas, preventive care, and long-term access. Unfortunately, in rural areas, We have a problem with access to physicians and hospitals. In fact, the average age of the rural doctor is 60 years of age, and this is even older than the average age of the average farmer. Also, it's difficult and expensive to recruit doctors to the rural areas, and hospitals are moving to more and more expensive guarantee plans in order to get any doctors to come to their areas. In rural areas where they're not so lucky to have a hospital, it is even more difficult to recruit. There are also vast differences involved in the amount of area that we have to travel for emergency care and for day-to-day care. And the Medicare reimbursement rate, which is slowly being equalized, has been a problem for us because rural areas are just as expensive to serve as urban areas. We fear that managed competition may have some problems for the rural patient. First of all, we just don't have the number of HMOs to allow for the idea that it's supposed to work with managed competition. Also, an aging population is less suited to the economics of HMOs, and the cost savings may not occur. To spend the last bit of my testimony on possible solutions, first of all, we think a single-payer system would provide the best service for the least cost. Number two, we need to expand tuition assistance in exchange for working in underserved areas. Three, we need to provide incentives to specialize in general practice. Four, we need to make increased use of nurse practitioners and others with direct reimbursement available. Five, we need to establish mobile health care clinics to assist in preventive care. Six, we need to restore the tax deductibility for premiums paid by the self-employed. Seven, we need to provide financial assistance for in-home care. Eight, we need to use a global approach to encourage preventive care. And this means providing transportation, outreach, childcare, and using the same doctor for continuity. 9, we need to increase the use of telecommunications to link our hospitals. 10, we need to encourage the sharing of expensive equipment. 11, we need to establish guidelines to prevent unnecessary testing and limit malpractice. And 12, we need a price freeze until comprehensive reform is in place. Thank you.
Thank you. That was very helpful. Our next presenter is Raul Yazagira, who is president of the National Council of La Raza. Welcome. Please proceed.
Thank you very much, Mr. Vice President, and thank you, distinguished panelists, for allowing us to present our testimony. My name is Raul Yazagira. I'm president of the National Council of La Raza. We're an umbrella organization for about 150 organizations that serve 2 million people. I want to talk to you a little bit about the Hispanic perspective on this terribly important issue. Hispanics are overrepresented in all of the major risk groups, i.e. the uninsured, the working poor, the unemployed, female-headed households, children, migrant and seasonal farm workers, the limited English proficients, and the homeless. Hispanics lack health insurance, both public and private. As of 1991, 12.9% of whites lacked health insurance, 20.6% of blacks lacked health insurance, but a whopping 31.5% of all Hispanics had no health insurance whatsoever. There is reason to believe that this number is increasing. For example, the number of Hispanics without health insurance increased by 89% from 81 to 91. We're concerned that as you devise a health care plan, that the nature of the Hispanic reality will not be taken into consideration. Our experiences with traditional approaches leaves us concerned. We share commonalities with other population groups that lack health insurance, but we are underserved for very different reasons. Hispanics are the working poor, and therefore the elements of any health care plan ought to understand that. We fall in between the cracks because the public system does not provide a place for us because we work. On the other hand, because we work at low wages without the benefits, we don't have private health insurance either. Let me speak quickly to the elements of what we think a health care plan should include. First of all, it ought to be universal. From our perspective, that needs to include the island of Puerto Rico, the American citizens who live on this island. Secondly, we believe that it ought to cover the undocumented citizens. I don't want to stress this point, but I think it's an important one that we need to focus on. First of all, we need to understand that health is a public health issue and that the disease doesn't respect the nationalities. Secondly, undocumented often live in mixed households, so that the mother may be undocumented, but the child may be documented. Thirdly, we're already paying for some of this health care through very expensive ways, using emergency facilities rather than preventive health care. And lastly, we've had an experience with employer sanctions, the part of the Immigration Reform and Control Act, and that shows that discrimination occurs when people are asked to be immigration agents. My time is rapidly at an end, but let me end by saying that we think that in terms of how do we pay for it, everything ought to be on the table, with the possible exception of regressive payroll taxes, which we feel will be a drain and a drag on job creation. Thank you very much for the opportunity to present our views.
Thank you very much, Mr. Izaguirre. Our final presenter on this panel is Michael Anderson, Executive Director of the National Congress of American Indians. Welcome.
Thank you, Mr. Vice President. My name is Mike Anderson. I'm the Executive Director of the National Congress of American Indians. We represent over 120 American Indian and Alaska Native tribal governments. We're pleased to be here today. I'm also a member of the Creek Nation, now located in the state of Oklahoma. As we've gone around the country talking to our constituents about healthcare issues, one thing that we hear over and over again is that this task force and this administration must take special consideration not to eliminate or diminish the services now provided by the Indian Health Service and by tribally operated programs. They're very afraid out in Indian country that somehow this government is going to diminish those services now available. There's a very long system and history of legislation specifically directed toward American Indians based on the special and unique government-to-government relationship the tribes and the U.S. have. This relationship is based on treaties and land exchanges in exchange for the protection of the government for American Indian people. This has also been stated as a policy of self-determination. The tribes must begin to adopt and enact their own health care programs. So when we talk about a national core benefits package or national insurance, it's critical that this health care framework currently in place for American Indians remain in place. Now, there are problems with it. It does need to be improved. It does need to be enhanced. And the statistics out there are grim. Over 33% of American Indians die before the age of 45. The sudden infant death syndrome is among the highest in the world. Over 31% of our people live in poverty. But these statistics would even be grimmer if the Indian Health Service and tribal programs of hospitals, ambulatory care centers, Alaska Native village clinics had not been in place. So we want you to make that message very clear that we want to preserve and enhance what's there now. Now, there are many areas and ideas that could improve the health of American Indians. If a universal system is proposed, perhaps tribes could have the option of participating both in the insurance program and also the tribal services available. So there may be a way through options that Indian people can improve their health. Last year, Congress in 1992, in the Indian Health Care Improvement Act, said that it's the goal, the official policy of the United States, to improve Indian health to the highest levels. So we hope that we don't take any retreat from those goals, which Senator Gore at that time and Senator and others supported. President Clinton made the pledge last year that he would improve and implement the goals of the Indian Health Care Improvement Act. So as we go forward here, that message is clear. And with all due respect to my other panelists, I think the group of American Indians deserves special consideration from the U.S. government. No other group of people in this country has had wars waged against our peoples. No other group has suffered religious and cultural attacks. No other group has been removed from tribal homelands. So while we're just 1% of the population now, we were once the sole inhabitants of this country. We ask this task force and this administration to honor the obligations to the First Peoples. Thank you.
Thank you very much, Mr. Anderson. Let me note that at the beginning of this panel, we were joined by Attorney General Janet Reno. Thank you very much. Let me make a couple of points briefly, and then we'll open it up for questions. I want to assure all of you that our plan is being designed with the special needs of underserved populations very much in mind. And the points that you have made here today are very helpful in considering exactly how best to do that. Having strong preventive services for low-income people, especially children, will be a major part of our plan, and that feature is especially responsive to some of the concerns that many of you raised in your statements here. Let me ask Secretary Shalala.
A question about underserved areas and underserved population. Just getting everyone insurance doesn't solve the problem, the infrastructure problem. And one of our concerns is about having providers there and available, whether they're sensitive to Hispanic health care needs, or Nancy, in your case, whether they're available in Wisconsin at all, even though Wisconsin has had some HMO experience. Could you all talk to us a little about what we ought to be doing to provide more healthcare professionals to serve inner cities, rural areas, places where we simply don't have the providers? And what kind of incentives you think we ought to use?
Secretary Shalala, I thought Wisconsin was rural until I started traveling in Montana and North Dakota doing healthcare seminars there. And it's so pretty out there, and there's such huge distances, and they're also put at risk even when they have to take a helicopter ride to the hospital. They really have a problem with attracting doctors. We have to encourage doctors to specialize in general practice. We have to encourage doctors to go out to those rural areas. It's expensive for people to be providing these incentive packages that the communities have to provide. They need help with those incentive packages, and I think the tuition programs that we have now that encourage people to serve in rural areas are a good idea. We need to have more of those. We also need to do something to make sure that people in rural areas can afford insurance, and that's where we have to have the health care deduction as a start.
But isn't it more than doctors? Because if we've tried all sorts of programs to get doctors out there. In other panels, people have suggested to us that we need a different model, that we have to think about healthcare professionals, not just a kind of medical model, and there are lots of other people that can provide some of these services, whether they're preventative or otherwise.
We need to include outreach services. We need to expand transportation opportunities. We need to do something to get the services to the people, and that's one of our suggestions, was to take it on the road. Start maybe a Winnebago that goes out to the rural areas and has at least low-tech services available as a start.
I would like to go back to my earlier point where I said it's necessary that we form some kind of partnership with local community-based organizations, with community health centers. Back in 1968, I'm from New Haven, Connecticut, we had with Yale University satellite health centers set up in the communities, but we also had from Yale University professional technical folks who would go in and train inner city folks so that they would be able to deliver some of the services. So I think we have to have a partnership. Those highly skilled who want to go into an inner city and work with the community and transfer some of the skills and some of the preventive educational things that we could do. Lastly, I just think it's important that we start to help organizations in our community identify potential students at the secondary level who want to go into a health care profession. We need a partnership with the federal government. Therefore, we would be able to work with the traditional black colleges to produce and have more folks available who would have the sincere interest to go back into the community.
Secretary Shalala, again, Larry Naik, representing the National Association of Counties. I would just reemphasize the point I made during my testimony, at least briefly, and that is that the infrastructure and service delivery system that you are talking about does exist through community health centers and through public health departments. And the public health departments exist in almost 3,000 counties in this country. the infrastructure is there, and the level of service and the quality, of course, varies, but we think if we beef up an existing system, if you use that existing system, then that preventive and primary care system will help not only provide additional access because they are in the communities, they're out there in both the urban inner city areas and the rural areas, but will also help to reduce costs in the future.
Madam Secretary, in our testimony, we addressed both of those issues, the infrastructure problem and the personnel problem. The infrastructure problem is enormously serious in our community. We showed examples where there simply wasn't a local primary care facility in very major urban areas that affected our neighborhood. There's a reason to believe that the infrastructure in the Latino community has been not given the proper attention. We also focus on the question of personnel. We're not replacing the Hispanic doctors that we have right now, and we need 2 or 3 times the number that we have. In other allied professions, dentists, physician's assistants, nurse practitioners, pharmacists, we're doing even worse. So that I think the solutions are there. You've heard them, we've heard them. The increased use of physician's assistants, the increased use of nurse practitioners. We know how to do these things. The question is, do we have the will? Are we willing to go out and do it? We know the incentives that do work, and we just need to make a determination that that's going to be done.
Madam Secretary, if I could just make one point on prevention. In Indian communities, particularly in the Great Plains area, fetal alcohol syndrome is a problem, a serious problem, totally preventable. And that's an area where I think with the proper education and the tools of both the tribes and Indian Health Service, that problem can at least be diminished, if not eliminated, because it is totally preventable.
I agree with that.
Mr. Rubin? There's a tremendous commitment, as you know, to deal with this question of the underserved and the uninsured. In that context, however, let me ask you a question. There's ultimately a conflict, I suppose, between the costs of doing things and the benefits that will be provided. How do you all feel about limitations on benefits, number one? How would you try to approach that issue? And secondly, how do you feel about the Oregon plan? They're related but different questions. Given, let me say, given the ideal would be to have full benefits, would be to have maximum benefits for everybody, but given the realities of having to deal with, in a societal sense, of the clash between costs and the provision of service to the undercovered and the uninsured.
I think one area I think that was mentioned just now is the prevention. I mean, that is an area that can bring down costs, I think, greatly, particularly in the Indian community. But I don't think any tribal representative or tribal member would accept the fact that Indians have to take a back seat anymore in the terms of elevation of health care. The official policy of the United States, reaffirmed last year in 1992, is to elevate Indians to the highest level. And so I don't think that we're going to have much support now, given the grim statistics, for reducing the benefits that are currently available.
I would make 2 points. One, there's some evidence to indicate that the existing system is more expensive than perhaps what we would be proposing. The 37 to 40 million people who are now uninsured are being taken care of. They're being taken care of in a very inefficient, expensive manner and without any preventive or very little preventive or primary care. So I would suggest that perhaps a new system might, in the long run, save money. Secondly, at least from our point of view, we think the benefit package, whatever is developed, ought to be applied to all Americans, not have different levels of benefits.
That's a tough one, Mr. Rubin, because I wouldn't want to be accused of setting standards. I think the greatest emphasis is on prevention. We really need to make prevention one of the most important features for the rest of the 90s. If we can prevent people from getting sick, we wouldn't have to worry so much about whether we have a minimum package or a package that gives people a range of menus that they could serve. But that's going to be a very difficult choice. I just hope that poor people, the underserved populations, aren't the ones who are really left out because of their inability to lobby or to have someone that can show their responsibilities?
2 points that I would like to make, Mr. Rubin. First of all, as to limiting benefits, I know that one of the proposals is to limit tax incentives to employers who provide greater than a basic care package. And I'd like to ask you not to do that. We don't want to give employers incentives to provide less. If they're able to provide more, we need to encourage that. Number two, as to the Oregon plan, I understand that it makes sense for the community to decide what they will cover. But what we would rather do, rather than limiting what can be covered, we would like to see shifts so that we're emphasizing more dollars spent on health care and not on paperwork. And that's one of our concerns with this managed competition proposal too, is that we might actually be increasing the number of levels of administration we have. So anything we can do to emphasize less spending on paperwork, more spending on people.
Let me try to be responsive directly to your question. I think the Oregon plan has two things going for it. Number one, it tries to bring an element of rationality, of logic. It tries to make decisions in the open about what we're going to do instead of being driven by a series of pressure groups or interest groups. So I think that's an important element in whatever we do. Secondly, I think it uses our state laboratories as a way of, I don't know if it's going to make sense or not in the long run. None of us do. But I think it gives us a chance to understand the pros and the cons over a period of time. So I think it's worth the approach.
Mr. Knight, could you talk a little bit about the county's view on the role of public hospitals as we go into healthcare reform? Would you perhaps see them organizing their own health plans, or how would you view them?
We view them as being part of whatever comprehensive system is proposed. We view them as being part of an AHP, for instance, and being obviously a provider. If we look at your system under managed competition with the federal government, the state government, a HIPIC, and then the AHP and the provider, we can see that county hospital, that public hospital, being a very, very important part of it. I think that you'll find that many of our public hospitals are, while perhaps not having the funds for infrastructure and for updating, are very sophisticated with respect to their equipment and their training facilities. That's why 26% of the doctors in this country are trained there. So we see them as being an integral part, being a very important part, having a sensitivity because of their history to the needs of the underserved that perhaps it does not exist in other hospitals.
General Reno?
In that connection, the county hospitals that I have observed seem to too often stand alone and don't have any sort of connection with a primary care center, then the county hospital, and then a more specialized regional center. What would you recommend in that regard? Well,
One of the ways is, one of our suggestions is to try to integrate both physical and mental health and community services in a better way, and I think your point is extremely well taken. Oftentimes it's a fragmented system, and you also need to integrate the support services that many of the individuals here have talked about, whether it be transportation or child care services that are necessary for those who need to get to a clinic or to a public hospital.
But how do the counties approach it? Because too often you get into turf battles with who's going to pay for what at the larger regional hospital. How would you recommend establishing a regional hospital with the really sophisticated, high-priced equipment, then the county hospital, then the primary care center, so that it was properly apportioned and you didn't have fragmentation, duplication, and the like?
Well, hopefully better planning on a larger regional area will help that, and I think that's what you have in mind and what we have in mind with respect to HIPICs, where you've got better planning. There are a number of examples of counties who do a pretty good job of that. Contra Costa County, California, Monterey County, Hennepin County, who in effect are practicing managed care at this time and trying to allocate those resources on a more rational basis. And I think we need more models like that, more examples like that.
like to address another issue. You've talked about prevention as being so important. You've talked about the ability to prevent the results of fetal alcohol syndrome. What about the problem for drug treatment for the underserved, and how should that be addressed, since I see so many problems arise that could be prevented if we provided the treatment up front?
Are you directing the question
to all of you?
To all of you.
I think something we've begun to see in tribal communities is an emphasis on healthy lifestyles and role models from the community leaders. And with the poverty, the despair that's been on many reservations, it's been very difficult to find role models. But I think the tribal leadership and others, community representatives, have begun to see that as an emphasis they need to place on youth and on the leadership in the community. And so I think that's a very, very strong positive development, and hopefully that will begin to yield some reduction in costs. As these children become older and enter in the workforce, they have some self-esteem, that they have the ability to enter the workforce as other American citizens. So I think that's a very positive development that we've seen that we need to encourage. In the Indian Health Service, it doesn't have to be just acute medical care. I think there are ways to integrate the community, also in some cases traditional medicine, whether it's specifically on the site or out in the community, but to have the government encourage those types of efforts, I think it can make a real difference.
I don't think there's any question that drug abuse prevention, drug abuse treatment makes an awful lot of sense. I think it will minimize your expenditures in the DEA area. I think it makes a lot more sense to work on the demand side of the drug problem rather than on the supply side, and I applaud your efforts in that direction. I think you're going to save money in jails. So I mean, it's so evident, so logical. I don't understand why we're not doing it.
One of the things that we used in Wisconsin that seemed very helpful, there was a very good link between the hospitals, the schools, and the social services, and having that link to treat people and treat them on different levels and know what the different levels are doing with the patient was very successful.
What troubles me is if somebody had 6 drinks tonight and drove drunk and plowed into somebody, killed them, and broke 2 arms, his arms would be treated tonight at a public hospital even if he were indigent. But I suspect both in this district and throughout the nation there are a large number of people on waiting lists who cannot get treatment except if they get arrested and taken to jail, and even then it's problematic. How does this fit into the whole question of health care delivery?
I think, again, we all are emphasizing prevention, education, wellness programs, and if you can keep people from taking those drinks, if you can keep people from using that needle, that's where we want to be. And I think we know how to get there. We just need to pay much more attention to it.
But I'm asking at the present time where we haven't done the prevention, and there are people out there on waiting lists who are acutely ill because of drug abuse who are not receiving treatment. How do we provide treatment in the present context?
I think your question points out the need that when we put together a health care reform package, it has to be a very comprehensive package, and that we need to include mental health care and outreach services as part of our package. We can't just treat the arms.
I'm not talking about the person who needs outreach. I'm talking about the person who has presented themselves perhaps at the public hospital, who is a crack addict, who is pleading for help, and there is no bed for them.
One of the things that, again, was our first recommendation was that a specific percentage, and perhaps a greater percentage of the funding than exists now, be set aside for the more traditional public health programs in our country, which include these preventive programs, which include education, which include drug and alcohol abuse treatment. One of the things that's going on, at least in our counties throughout the country, is that we're finding that because of structural problems and because of this current recession, that we're finding significant layoffs of employees and reductions of services in counties throughout our nation. And in many cases, they are in the public health area because we don't have choices in other areas. There are certain mandates. So where you have some decision-making authority at the local level to reduce programs and reduce services, that's where you do it. And unfortunately, it happens with respect to community clinics. It happens with respect to drug and alcohol abuse. It happens with respect to other public health education programs. So attention, in my opinion, needs to be made on that front end. You need to take a significant portion of the funding that you're talking about and put it on the front end, not wait till you have to treat people.
If I could paraphrase what I think is coming out of this exchange, and having the law enforcement perspective here is extremely valuable, as this is showing. You're saying that when we look at the problems of the underserved, we ought to also include treatment for addictive disorders and drug and alcohol abuse, bearing in mind that some of the old stereotypes are now known to be no longer true, and that there are, in fact, treatment strategies for many addictive disorders which have very promising outcomes. And what you're saying in response is that it ought to be a comprehensive package if we're going to get at the real needs of all of those who are underserved. And Mr. Anderson, just to use the people you are speaking for here today as an example, you brought up fetal alcohol syndrome and fetal alcohol effects, which are related to fetal alcohol syndrome, though not quite as severe in the intensity. Both of those conditions show the enormous savings over time which can come from an effective and comprehensive approach to addictive disorders, which can avoid a lot of these problems, including the trauma that is seen at the emergency room as a result of drunk driving. But let me call on Carol Rasco.
Mr. Knight, you've mentioned several times in your testimony and then in follow-up the function of the public health role, and have emphasized it as an infrastructure that is there. Could you talk a little bit about how you would see these set-aside funds flowing, and also what role you see for the purchasing co-ops in assuring those functions through public health?
Well, I guess there are a number of options. I don't necessarily see them flowing from the federal government down through the states to an individual county health department, but perhaps you might look at it either on a statewide basis or a regional basis when you set up the HIPICs. There might be a way of providing some of the funding that is brought together through this managed competition, and perhaps taking some off the top, a certain percentage that is then dedicated to community health departments, public health departments, county health departments, even community health centers that can be used for these preventive upfront investments. So perhaps it's done on a regional or a statewide basis and allocated on some needs formula. We'd be happy to work with you on trying to figure something like that out, though, the specifics of it.
First of all, let me assure panelists, Ms. Anderson in particular, that we will not recommend a reform that increases paperwork. I can guarantee you that, that it will be one that reduces substantially the paperwork in the system. Let me ask a different question, though, of all of you, which is, there have been a number of programs that have demonstrated success at bringing healthcare professionals into underserved areas, whether they are rural areas or urban poor areas. What has been more elusive has been keeping them there for a long period of time, or sustaining a presence. And I'm wondering whether you have any ideas or any demonstration projects that you think have worked that would sustain the adequate healthcare infrastructure over a longer period of time.
One in particular for American Indians has been the fellowship programs from the Indian Health Service, and also health professional training for American Indians and Alaska Natives in the area on site. And so if you can, the key I think for us is if we can develop a health corps, health professionals from the tribe, from the reservation, that's their base. And so I think that might be more effective than bringing in people for a couple of years to service the community. And so I guess our movement would be to develop expertise on site rather than importing it from other areas.
We would agree with that. All the knowledge that we've gained over the years has indicated that if you recruit people from the barrios, from the inner cities. They will return to the barrios. That Hispanic doctors are more likely to practice in Hispanic areas than non-Hispanic. So I think if we work at the recruitment side of it, rather than simply trying to attract somebody who's not from that area, I think your chances of success will improve dramatically.
One program that Farmers Union sponsors is the Green Thumb Training and Employment Program for older workers. And that program has provided health training to older workers who needed jobs. The program operates so that the people have to work in a community service field, but expanded programs like this, where the people who need the jobs get this training and then can go out to the communities. And many times they're working with their friends and neighbors, and so you overcome some of the outreach problems that you otherwise would have, because they know who needs the help, and it's people that they know. And I think an expanded use of programs like this could be very helpful.
I would also have a forum in the historical black colleges, in the medical schools, and we'd be dialoguing with the potential people who are going to return to these sites to discuss with them what would make it conducive for them to stay and have that kind of interaction. I think you could get great results towards having some kind of focused discussion with these potential health providers, physicians, people who want to go back and serve, but also there are economic reasons why they might only stay 1 year or 2 years. But I encourage you to go to the sites and interact with those potential folks who would be going back.
I have one other question about the current Medicaid program, not the long-term care piece of it, but the acute care piece. One thought is that that program ought to be directly folded into the new system. That is, individuals who are now Medicaid eligible ought to be able to go to purchasing cooperatives and so on like anybody else. It may be that they have subsidy on their payment to that cooperative, but that basically they should then be able to choose among plans like anybody else and just be part of the normal system, which would essentially end Medicaid as a program. Do you have any thoughts on that, whether that's the right way to go, or are there dangers in going in that way?
I would be supportive of that for a couple of reasons. First of all, it establishes one class of folks. Secondly, we understood very clearly that the differentials in the way states administer the program is a very serious problem, and I think that that approach that you suggest would eliminate that problem.
I also would like to see a universal system. I don't want to see a tier for one, a tier for others. So I certainly support my good friend Raul Esguerra's statement 100%.
Perhaps another approach to this, we would agree as well. Our policies would support that, having one system. The other thing that exists now that the Attorney General mentioned, I think, is a bit of turf battling that's going on with respect to counties that provide indigent health care outside of Medicaid, which is done in 20 some odd states, 30 some odd states. Oftentimes there's this battle to go on because of the financing aspects and the lack of funds to try to make somebody Medicaid eligible, or vice versa, get them off the Medicaid roll so it becomes somebody else's financial responsibility. And that turf battle and that pulling and tugging could be alleviated through making one system. Mr. Rubin?
Yeah. Leaving aside for the moment the totally indigent, would you, and leaving aside also the question of how all of this is going to be paid for, would you, well, that's not an irrelevant question, but would you include in this some kind of a provision, a co-bearing of expense, however slight, as a way of giving people that piece of the consideration when they make decisions about seeking health care? In other words, however the system is paid for, and leaving aside the truly indigent, would you have some component of use that involves some payment as a way of causing people to exercise a self-discipline with respect to using the healthcare system?
Provided that you do a lot of health counseling and education with it. Certainly the HMO experience suggests that some form of very modest co-payment enforces some kind of discipline and does lower your costs. And so I can understand why prudently you would want to look at that as a cost-saving device. But I think you gotta also have a program that makes people much more in charge of their own health and becomes more of a triage, a personal responsibility for triage.
Just to follow up on that point too, this type of proposal, means testing in the Indian health area, has been proposed before, and the tribes have uniformly been opposed to that because the deal that was struck back when the treaties and the land secessions were made was that health care would be provided for the tribes. And so unless the land's going to be given back at some point, I think the tribes will oppose means testing.
He's not talking about means testing. He's talking about a co-payment.
Yeah, some form of co-payment, however.
But based on some type of income requirement. You're saying excluding the totally indigent. So there is some type of income requirement that the person would have to meet. But I wanted to also offer that I think that some tribal governments, particularly ones that are doing well now, I think the movement is to build clinics and provide their own health care as well, to supplement it on a government basis, but not at the individual level. At some point, as the incomes rise to the level of non-Indian society, that could be a possibility. But right now, we're not even close.
Mr. Rubin, if I may speak from my personal experience for a minute, I used to practice law, and there were some clients that had no money, and I had to help for free. Those clients oftentimes called me the most often because they were paying nothing for the services, and the people who were paying something realized the value of the service. And so I think that if there is some small co-payment, maybe it will help people realize the value of the service. The problem is that sometimes you have people that they're not indigent, but their income is very low. I read a study the other day saying in one state the farmers were making $13,000 a year. Now they're paying over $5,000 for the health care coverage. And you can, I mean, those numbers are obvious what happens. And so if there is some kind of co-payment, it needs to be low enough so that we still allow them the ability to use the service, because if the service is there and the co-payment keeps them from using it, it's like not having the service.
Yeah, no, I agree with that. My notion was, I wasn't a notion, it was a question of a co-payment, but one that people could afford.
Secretary Shalala?
I'd like to go back to the Attorney General's question about related to substance abuse. If we move to a system of more managed something, whatever we end up calling it, how would our responsibilities for substance abuse and violence change? Do you see the structure? Should accountable health plans be responsible for substance abuse treatments, or will we need to maintain a separate safety net capacity? And if so, how should we pay for that?
Well, I think I partially addressed, if I understand your question, partially addressed it, that I think it ought to be part of a reform system, both with respect to treatment, but also you need to look at it from the point of view of prevention and education and upfront investment, which is not necessarily going to be part of the traditional treatment system. So I think you do need to have a separate system that addresses that in the community with outreach programs and the availability of people to come into clinics and treatment centers. And I guess I would go back to the suggestion about perhaps on a regional or statewide basis, when you set up a system to provide that treatment, that perhaps something come off the top to be used for upfront investment in not just in alcohol and drug abuse, but in lots of other preventive programs, that you do need to use a different system. It can't be put into, most HMOs don't provide the kinds of services that community clinics do or public health departments do.
Well, you could require the health plans to contract out with the existing safety net providers, for instance, with public hospitals, with clinics, with community health centers. I'm trying to figure out how much of this, goes in the mainstream and what the structure is as we're dealing with very critical issues like substance abuse.
I would like to see it part of a menu of choices that clients would select. It is a very serious problem in our country, and until we face up to the fact that it is just as critical as someone who has cancer or heart trouble, I think we're fooling ourselves. So I would like to see it as important as any other choice that a client would be able to go into a hospital or physician and ask for the kind of assistance to deal with this illness.
I think we need to differentiate between people who voluntarily are seeking this kind of treatment, and for those folks, I see no reason why it should be outside of the system. I think that all of these services ought to be available within one system. The other category of people are those who involuntarily need to be assigned to drug abuse programs. That is to say, those who have come under Attorney General's jurisdiction, who have been caught, who have been sentenced to jail, and it's found that they also have a drug abuse problem, as a good significant number of people do. For those folks, I think that that's a more difficult issue, and I think we need to be able to build those kinds of services into the penal system.
General Reno.
Why? Oftentimes it's the luck of the draw.
Right.
One young man didn't get caught and one did get caught. Why do you provide two different systems for him?
Well, but I don't. I mean, I'd like to see one, but the reality is that in one case, you have the coercive power of the state to be able to compel somebody to do so, to receive a certain kind of treatment. And the other, you can only rely on education and suasion of one kind or other to entice people who do need those services to come into the system. So I'm making a distinction between those who are walking around who do need those services, but need to be convinced in other ways to use those services, and those who come before the penal system and where you have more of a say as to what happens.
Secretary Shalala mentioned something else that's equally as important. It was often said that during the 1980s, that drug abuse was the greatest public health problem. There are many of us that think that youth violence is now the greatest public health problem. What responsibility do we have for a 13 or 14-year-old who is acting out, just doing things that forebode terrible problems for the future, who could be treated by proper emotional, psychological support at this point? Does that come into the major system, or is that treated separately?
I think violence needs to be recognized as a public health issue, and I think we need to both increase our understanding of the health, mental health and otherwise, causes of that problem and the societal impact of that, and how to treat it. I'm not sure that's one area where, unlike other areas where we've got the experience as a matter of will, I think in the area of recognizing violence as a public health issue, we've got a long way to go.
General Reno, I worked as a prosecutor, and the people that were the substance abusers, we didn't have a good way to treat. They fell through the system. Eventually, they ended up dying. I mean, they would keep coming back to the system, and they might get a jail sentence or a prison sentence, but it just didn't help them. And until we develop some kind of alternative treatments for these people, and I know some programs have been tried, but that's an area we definitely need to work more in. And I think the reason we're having trouble answering the question is because right now there's not a good answer for it.
There are good answers for that 13-year-old. You talked about prevention. You talked about counseling. You can talk about tutoring. You can talk about so many different interventions that are just what you're talking about in terms of substance abuse and other areas. A counselor for that 13-year-old who does follow-up, who works with him day by day, who tutors him, is as important perhaps to that child as the inoculations that you're going to try to give him when he's 2 and 6 and 8. And it is treatable.
The issue you raised, really, I guess, is the public policy issue on interdiction or prosecution of drug abusers and others, or prevention and treatment. Obviously, I think if you looked at a 10-year plan, there's going to be savings over the long run if you embark on a very strong prevention program, but the upfront costs are going to be very expensive. Now, whether those monies come from interdiction programs or from the law enforcement budget is some choice that you'll have to look at, but it really is a long-range plan versus the short-term costs, which are going to be very high.
But both violence and drugs, if you look at what drugs are causing public hospitals in this nation in terms of just primary treatment for the drug problem, then tuberculosis, AIDS, and related trauma, it is probably the greatest single burden on at least the public hospital system that I've seen. If you start looking at what violence is doing to our youth in terms of emergency room admissions, long-term hospitalizations, and deaths, it is probably the greatest single cause of death of young men ages 15 to 25 amongst the black population. And it just seems to me that in our thinking, we've got to galvanize into this area. We can't say that that's long range. It's right here, the greatest burden I see.
I don't think anybody's disagreeing with you, but what we're saying is that we tended to look at that as a justice system, as a corrections system, and the thought is, and you seem to be leading the charge, and we applaud you for that, is to begin to look at that as in societal terms and also as a public health issue, recognizing that as a public health issue is an emerging concept, one that I think we would be very supportive of.
I have some very helpful information that I will get to you, Ms. Attorney General, that was done in the state of Black America in 1989, of extensive research done by Professor Bell from Harvard University and several others. We've done 4 or 5 extensive articles in this area. I will make sure I get that information to you.
We'll look forward to receiving that material. In the brief moments remaining for this panel, I'd like to ask yet another question and ask you to keep your answers to this one very brief. We face a problem in meeting the needs of underserved populations in steering healthcare providers into those communities where there are large numbers of underserved Americans, and to those parts of the country where there are large numbers of underserved Americans. A couple of you on this panel have talked about the importance of recruiting doctors and other healthcare professionals from among the populations that have historically been underserved. We have taken note of that recommendation, but what other incentives could you recommend for steering these providers toward inner city areas, rural areas, Indian reservations, etc., where there are large numbers of underserved Americans? Any brief responses to that one?
Just a quick one. The National Trust Plan idea that's been proposed as a way for people to return back to the communities, whether it's Indian reservations or inner city areas, to give service back in return for some forgiveness of student loans, I think is a terrific idea, one that needs to be tried in a lot of different areas. I think that's one way that we can bring in idealistic young people who want to help, who want to be part of, serve as a public servant, and I think that's a great start.
Something like an expansion of the National Health Service Corps model?
We know that monetary incentives do work and are a factor, but we found in our health clinics and the part of our network that doctors are a major problem and allied health professionals are a problem, but that one unrecognized element is that professional isolation. They just feel like their own career is attenuated, and so ways of making sure that they get professional support, either subsidizing their trips to professional associations, meetings, some way of connecting them to their profession is enormously important.
I was going to comment on the same thing. Anything we can do to link them with other doctors so that they feel like if they're in a rural area that they're not practicing out there on their own. They need to have those additional links.
All right, very good. Let me express our thanks to each one of you for participating in this panel on the underserved. You've been tremendously helpful to the task force, and we want to thank you very much as we move on to the next panel. Thank you. Thank you. We'll make a speech about that. Sure. All right. Fine. Wish you a good day. With that, wish you a good day. Thank you very much. Thanks for coming, Bob. This is the... Okay. All right, our next panel is a panel of general health care providers. We're going to ask this panel to address the following question. As frontline providers of service, what is the best step we can take to control costs inside the healthcare bureaucracy. The presenters during this panel will include Virginia Trotter Betts, President of the American Nurses Association, and a personal friend. It's great to see you. Dr. Jack Harris, President of the American Dental Association. Thank you for joining us. Ann Elderkin, President-elect of the American Academy of Physician Assistants. Thank you. Dr. Reeve Askew, who is a member of the Board of Governors of the American Chiropractic Association. Sheldon Goldstein, Executive Director of the National Association of Social Workers. Thank you very much. And Bryant Welch, Executive Director for Professional Practice with the American Psychological Association. Thank you for joining us. You heard the question that we're putting to this panel as frontline providers of service. What is the best step we can take to control costs inside the healthcare bureaucracy? We are interested in your views, and we'll begin with Jenna Betts. Thank you very much. Please proceed.
Good morning. The American Nurses Association believes that the single best cost savings measure is to move away from the expensive medical model of illness care that now exists in our country. Organized nursing believes that the high costs of physician-centered, hospital-oriented acute care can be greatly reduced through a new emphasis on primary care delivered in community-based settings that are accessible to everyone. By community settings, we mean delivery of an array of health services in schools, work sites, daycare centers, and community clinics, as well as home-based care, thus limiting the utilization of specialists, hospitals, and expensive technology. If we facilitate primary health care delivery, which includes prevention, early diagnosis, uncomplicated illness treatment, and self-care and wellness education, we can reduce our overall health care costs while significantly improving our personal and national health at the same time. Every dollar spent on preventative care will eliminate $4 in subsequent acute care expenditures. Lack of activist public health and primary health care delivery has taken its toll in many ways, as you have heard earlier, such as overburdened emergency rooms, unnecessary morbidity and mortality from preventable or manageable diseases, high infant mortality rates, and the world's most expensive medical care services. In our country, we spend 90% of our health care resources on acute care and only 10% on prevention and primary care. We must reform the U.S. health care delivery system toward a consumer-centered, community-focused model. In order to restructure the delivery system for universal access to primary care, a cost-effective mix of health providers must be available to deliver that care. This can only be achieved by removing the anti-competitive barriers that prevent non-physician providers, including professional nurses, from working within their full scope of practice. Currently, 70% of physicians are specialists, not generalists, and professional nurses functioning in an advanced practice role are ready to deliver primary care and can do so at a 40% savings. In the world community in which we live and compete, there is a growing awareness that healthcare workers other than physicians are able to provide quality care at a lower cost, that hospitals using sophisticated technology are not the only places where consumers receive quality care, and the medical model is not necessarily the appropriate model for a healthcare delivery system. Remodeling the U.S. delivery system toward health is essential to controlled cost, and we believe is abundantly congruent with increasing access and enhancing quality outcomes.
Thank you very much, Virginia Betts. And our next presenter is Dr. Jack Harris, President of the American Dental Association. Welcome. Please proceed.
Thank you, Mr. Vice President. Thank you, members of the panel. The American Dental Association believes that probably the best way to control cost in whatever system is designed is to build specific checks and balances within the system itself. And I think that the oral health delivery system in the United States provides an example of that. 4 basic principles: preventive measures, accountability, competition, and patient involvement in decisions and outcomes work together to keep oral health care costs under control. How effective is this system? Well, the Health Care Finance Administration projects that the rate of growth in dental expenditures from now through the year 2000 will be 1/3 lower than the rate of growth in total health care expenditures. The growth in dental expenditures will average 6% per year, compared to 9.5% for hospital expenditures and almost 11% for physician services. The first of the 4 cornerstones of dentistry's system for controlling cost is preventive measures. In addition to preventive treatments in the dental office, this measure includes making patients aware of personal habits that promote oral health. The dental profession encourages employers to emphasize preventive care in their dental plans by covering 100% of the cost for diagnostic and preventive services. Routine oral exams, teeth cleaning, application of fluoride and sealants, and other treatments designed to stop dental diseases before they start. Now, we acknowledge that the scope of dental practice does not routinely include the catastrophic illnesses that are within the scope of other health care providers, but it is clear, however, that an effective system to control overall health care costs must encourage patient education and other preventive measures that will reduce the incidence of these catastrophic illnesses. The principle of accountability, which is focused sharply in dental health benefit plans, is an important factor in cost containment. Its major elements include utilization review, defined reimbursement levels, annual benefit ceiling, and patient cost sharing in the form of deductibles and co-payments. Competition is inherent in dental care delivery system. It results from patient freedom of choice, which encourages cost and quality conscious consumers to access dental care from a range of qualified dental professionals. The fact that 53% of the dental health care dollar is paid out of pocket further reinforces this concept. Finally, the practice of dentistry in the United States is characterized by a high degree of patient participation in both decisions and outcomes. This patient involvement in decisions about treatment for more complex oral conditions and diseases is a major factor in controlling cost. Costs are more likely to be driven up when none of the responsibility rests with patients and treatment is dictated solely by coverage. It should also be noted that over 80% of all dentists are general practitioners. As a result, there's a built-in gatekeeper mechanism, which is present in the dental delivery system to assist the patient in developing cost-conscious treatment plans. It is our belief that these measures go a long way to keeping the cost of dental care down in the United States, and in some measure could be applied to whatever medical system is devised to also keep those costs down. Thank you very much for allowing us time.
Thank you very much. We'll now hear from Ann Elderkin, President-elect of the American Academy of Physician Assistants. Welcome. Please proceed.
Thank you. On behalf of the American Academy of Physician Assistants and the 22,000 practicing PAs we represent, I want to thank you for this historic opportunity to present our views on national health care reform. Physician assistants, PAs, practice medicine with supervision by licensed physicians. We provide a broad range of medical services, including diagnostic, therapeutic, and preventive services that would otherwise be provided by physicians. We believe that increased utilization of PAs and other non-physician practitioners can help control escalating healthcare costs. Enacting policies at both state and national levels that seek to achieve this goal will not only improve access to health care, but accomplish this in a way that reduces both near and long-term costs. The specific policy recommendations we would make to achieve these goals include the following. First, recognizing PAs and other non-physicians as authorized providers of health care under the new system. Second, encouraging states to enact more flexible laws and regulations regarding supervision and scope of practice for PAs. Third, transferring Medicare GME dollars from physician resident training to increased support for the training of non-physicians. And fourth, amending existing federal health programs, including Medicare, to the extent they exist under a new national health program, to provide reimbursement for PA services in all settings. In our written comments, we go into greater detail on each of these proposals. In many respects, the PA profession has been preparing for the Clinton administration for the past 25 years, because we are already providing quality health care to millions of Americans. many of whom reside in federally designated underserved areas. Certainly, reform must place a premium on the utilization of cost-effective providers like PAs. Much of the health care reform debate has thus far focused on financing, with little attention paid to the actual delivery of health care. Who will provide health care to all of the individuals who will now have the financial barrier removed? Where will we find all the providers who will be needed to deliver health care once all Americans have a health care credit card? One answer must be utilization of physician assistants. As the primary care provider of choice for millions of Americans, PAs have a proven track record of delivering cost-effective quality health care. This point was reinforced by a recent report on health care in America by the Macy Foundation. Unfortunately, the report identifies the shortage of PAs as a major impediment to successful health care reform. Many health policy makers have noted the critical shortage of primary care providers. Currently, fewer than 30% of physicians practice in primary care medicine, and only 15% of this year's medical school graduates expect to enter primary care residency. By contrast, nearly 50% of all PAs practice in a primary care specialty, and nearly 60 of the 1992 graduating class chose a primary care specialty. As the director of the health department of the city of Somerville, Massachusetts, I am keenly aware of the difficulty in recruiting scarce primary care physicians to our city. We need to remove barriers to effective utilization of all primary care providers. We have today an unprecedented opportunity to give real meaning to the concept of the team approach to health care. The PA profession is standing by, ready to assist you in this endeavor. Thank you.
Thank you very much. Our next presenter will be Dr. Reeve Askew, member of the Board of Governors of the American Chiropractic Association. Dr. Askew, please proceed.
Mr. Vice President and members of the panel, good morning. I am Dr. Reeve Askew, a member of the American Chiropractic Association's Board of Governors and a practicing chiropractor in Easton, Maryland. On behalf of the American Chiropractic Association's 22,000 members, I would like to thank you for this opportunity to address the task force. The American Chiropractic Association welcomes the opportunity to work with you towards systemic reforms that will guarantee access to affordable health care for all Americans. For years, the American Chiropractic Association has supported universal health care for all Americans, regardless of their income, controls on overall health care spending, and guarantees of consumer freedom of choice in the selections of licensed health care providers. America's 45,000 doctors of chiropractic are anxious to help tackle the problems that have left far too many Americans exposed to the great physical and economic risks associated with their inability to obtain appropriate health care services. You have asked me to address the issue on how I, as a frontline provider of care, would suggest controlling health care costs. Several methods of controlling costs have been mentioned. Unfortunately, many of these can be accomplished only at the expense of some degree of health care access or quality. For instance, some view limits on the scope of standard benefits package as one way to reduce cost. However, such a proposal may put at risk individuals with special health care needs, such as the disabled. In addition, strictly limited benefits package might erect barriers to the millions of Americans who choose to receive their care from licensed alternative providers such as chiropractors. Clearly, this would reduce access to health care services at a time when we can least afford it. Unfortunately, this is often the case with health care policies. They can cause as much as they cure. I certainly don't claim to have answers that will avoid unintended consequences, but I do feel that my suggestion can help pull down costs without unacceptable compromises in health care access or quality. First off, expand access to non-MD health care providers. Everyone agrees that expanded access to primary care is essential. However, failure of medicine to provide an adequate supply of primary providers is well documented. In order to fill this gap, policies must focus on expanding access to non-MD providers such as chiropractors, nurse practitioners, and others. Today, these providers are meeting the primary care needs of millions of Americans and have done so for years. Nearly 19 million Americans received health services from a chiropractor in 1990, and according to one survey, 85% of employers provide coverage for chiropractic care. Another one is freedom of choice. Of course, suggestions to increase access to alternative providers begs the question, how? First and foremost, government policy should provide an ironclad guarantee that will guarantee patients will have their freedom of choice to choose their health care provider. Other ways is integrated health systems. Alone, non-MD providers may not be qualified to treat all conditions presented to them, but this is no reason to dismiss the idea of utilizing them to a greater degree. Federal health manpower programs, existing programs like the National Health Service Corps should be fully funded and expanded to include all licensed health care providers as eligible participants. And finally, in conclusion, Mr. Vice President, if we are to expand access to health care coverage to everyone in this country, health costs must be controlled. The American Chiropractic Association believes that this can be achieved in part by expanding access to alternative providers, guaranteeing patients the freedom to choose them, and expanding federal health manpower and research programs so that all licensed healthcare disciplines have access to them. I thank you for the opportunity to share my views.
Thank you. Our next presenter is Sheldon Goldstein, Executive Director of the National Association of Social Workers. Welcome. Please proceed.
Thank you, Mr. Vice President. On behalf of the 145,000 members of the National Association of Social Workers, I want to thank you for the opportunity to present NASW's views on containing costs within the Healthcare Reform Initiative. Professional social workers, as you may be aware, practice throughout the health and mental health care delivery systems in health planning, policy, administration, as well as public health, health promotion, and health education. Professional social workers also serve as primary health care and mental health care providers in a wide range of private and public settings. NASW has developed a healthcare reform proposal, a single-payer plan, that we believe to be the ideal. It addresses cost containment among healthcare providers. It also addresses cost containment system-wide. It is a single-payer national healthcare program that would be administered by the states under federal guidelines and would offer comprehensive health, mental health, and long-term care services to all Americans. In brief, the cost containment features the NASW recommends through its single-payer plan are: 1, the single-payer system itself, in which the government would collect and disperse the finances for health care, would save over $67 billion in administrative costs, according to the General Accounting Office. Other estimates range from $72 billion to $150 billion per year in administrative costs. It would use global budgeting through the states to cover all covered health expenditures. State regulation of the funds for capital expansion and the purchase of highly specialized equipment. As you may know, there are more MRIs in the city of Seattle, Washington than in all of Canada. Other recommendations for cost containment that are most directly related to healthcare providers include the use of negotiated fees and fee schedules for physicians and other health care practitioners, including social workers. The use of utilization review to screen for and evaluate the appropriateness of care. A benefit design that includes a full continuum of appropriate care so that individuals may receive more cost-efficient care in outpatient community-based settings or partial hospitalization settings, as opposed to the most costly inpatient settings. Additionally, there are features in the NASW plan related to service delivery that we believe will ultimately lead to greater cost savings. Coverage for preventative care, including immunizations for all children, coverage for comprehensive mental health care, which we believe will result in fewer visits for unnecessary medical care. Currently, individuals who do not have mental health coverage may inappropriately seek help from a health care provider when their problem stems from an emotional or behavioral base, and recognition of the ability of duly regulated non-physician providers to provide quality, cost-effective care. Thank you very much.
Thank you very much. Our final presenter on this panel is Bryant Welch, Executive Director for Professional Practice with the American Psychological Association. Welcome.
Mr. Vice President and distinguished members of the task force, on behalf of the American Psychological Association, it's an honor to appear before you. Despite our enormous unmet need for mental health care, there are two structural anomalies wasting millions of dollars in mental health, creating what can best be characterized as a waste and want mental health system. First, we are using very expensive inpatient treatment for two large patient populations who research shows could be better treated in outpatient settings. Indeed, evidence documents that all recent increases in mental health care costs have occurred either in inpatient alcohol and drug treatment or in inpatient adolescent treatment. At the same time, research now concludes that nearly 50% of these patients could be treated as effectively or more effectively in outpatient settings. If we simply look at the insurance and economic incentives that we have created, it's obvious why this is the case. First, hospital-based inpatient treatment is often covered at 100% insurance reimbursement with little or no expense to the beneficiary, while cheaper outpatient insurance benefits are extremely limited and require significant cost sharing. The family's decision is whether to keep the disturbed and disturbing patient family member at home with outpatient treatment or instead to put the patient in a hospital, giving the family respite and eliminating their entire financial burden as well. Second, when the Medicare DRG system was established in 1984, it was not applied to psychiatric units. As a result, hospital investment dollars quickly shifted into psychiatric facilities, doubling the number of such facilities between 1984 and 1988. This, of course, led to much greater hospital marketing for patients. It is this dual dynamic which has created the cost problem in mental health care. The second anomaly in the mental health system is in the outpatient sector, where increasingly we are providing a level of coverage that treats the healthiest patients and excludes the sickest from any care at all. Managed care companies and more recently other third-party payers have redefined traditional outpatient care to make it so brief it is often entirely inappropriate for those in greatest need. Limited 20-session treatments for healthy adults going through difficult transitions, such as divorce or death of a loved one, can be justified and are good mental hygiene, but we cannot treat a learning disabled child or an abused child in the same limited 20 sessions of crisis intervention. The benefit simply does not meet the need. Making matters worse, most managed care companies create de facto barriers, making it difficult for patients even to get the 20 sessions. We hope that you will decide to put an end to this waste and want mental health system and build a more cost-effective and humane system. Psychologists recognize that as a provider group in such a system, we would have to accept a fee schedule and certain reasonable price controls. We would also willingly incur a mandate to see a certain percentage of lower fee patients whose economic circumstances do not permit them to meet their copay obligations. We ask you to end the waste and give us the chance to end the want. We thank you for including us in the enormous outreach effort you are making on this issue.
Well, thank you very much. And before going to questions, let me note that at the beginning of this panel, we were joined by Tipper Gore, who has been working as an advisor to the Healthcare Task Force on mental health care issues. And let me begin the questioning by trying to bridge the last panel and this one by asking you whether or not you could make a recommendation on how we can ensure the use of non-physician providers, such as those represented on this panel, to serve underserved areas and populations, as we also address how to get more physicians to those populations. Yes, Mr. Goldstein.
Yeah, I'd like to address that. Social workers, by virtue of our number and where we're located, are in every area of this country. For example, in Illinois, the state where I'm most familiar with, there are 34 counties where the only licensed provider of mental health services are social workers. There are no psychologists and no psychiatrists, so by virtue of our numbers and where we are located, we would help very much in solving that problem.
Mr. Vice President, to follow up on that same line of argument, there are psychiatrists in only about 1/3 of the counties in this country. Psychologists would fill about 60% of the gap, and as Mr. Goldstein indicated, social workers could fill the rest. We have also developed a number of pilot projects in which we're trying to make more effective use of linkages and communication systems between psychologists and general practitioners in the rural areas, so you can combine their expertise and provide more mental health expertise in those rural areas.
Mm-hmm. Yes.
Mr. Vice President, in order to utilize the services of physician assistants more in the underserved areas, federal and state policies have to remove some of the barriers that we have encountered at both the state, federal, and local levels. Those include adequate state laws for prescriptive privileges, fair and equitable coverage of reimbursement of services, scope of practice laws, and supervision laws that allow effective utilization of our services.
I would echo that. That is exactly the situation for advanced practice nurses. If we're talking about numbers, the nation has 2.1 million professional nurses that are in every community and every rural area in this country. However, state licensing laws, state regulation, prescriptive authority, and especially very inequitable reimbursement practices, both in the public and private plans, prevent advanced practice nurses and professional nurses from offering their services directly to the community with the opportunity to dramatically decrease costs. And so we would echo what the Physician's Assistant Group said, and certainly hope that as the task force looks at reconfiguring a reform system, you would look at Medicare and Medicaid in a wholly new way also. They also reimburse acute care services and do not reimburse for the most cost-effective care, which is preventative care.
Well, let me ask you to elaborate just a little bit on what you were talking about when you used the phrase prescriptive services. And you mentioned this as well, Mr. Welch. If non-physician providers dealing with mental health care encounter a patient who requires medication that can only be prescribed by a physician, what alternatives are there which you have in mind, apparently, when you talk about changes in prescriptive services to either make that link between the non-physician provider and the physician easier to bridge, or what other solutions
There are a number of proposals that have been advanced. Psychologists have talked about adding a year to their training to develop expertise in prescriptive drugs. At the present time, 80% of all prescriptive drugs are prescribed by physicians who have very, very limited mental health training. And even the American Medical Association and the American Psychiatric Association, in a joint communique, have acknowledged that that does not provide high-quality prescriptive performance. So our position is that if we could remove some of the barriers that are kept in place to practice and let the professions who are motivated to add to their training to provide that service, that we could then get the expertise out into the rural areas and in other areas where people are underserved.
I would like to respond to the question not only about mental health. I will do that first, and then I would like to take it a little bit broader. In terms of mental health care, both psychiatric nurses and advanced practice nurse practitioners who are comfortable with psychotropic drugs are excellent practitioners in community mental health centers and in state-run psychiatric hospitals. But in both of those settings, there are tremendous barriers that prevent these advanced practice nurses from having prescriptive authority, even if they are the best trained. Therefore, the state systems especially have relied on, in mental health care, foreign physicians to look at clients, maybe not even know them, certainly are not following their cases, but they do have prescriptive authority. It really doesn't make sense, especially when community mental health center budgets spend too much money to have physician oversight when non-physician providers could do the very same care. But it's also true in other areas that doesn't make financial or quality sense for advanced practice nurses as a part of their training to have pharmacology, assessment, diagnosis, and then to only have their practice restricted if they are caring for the most impoverished situations. In Tennessee, an advanced practice nurse scope of practice differs whether she's caring for the very indigent or whether she is caring for the middle class. It doesn't make logical sense, but it makes economic sense for other practitioners who do have full prescriptive authority.
Ms. Elderkin.
One example linking back to your question earlier about serving underserved and some of those barriers is that a year ago we took a look at the states which allowed physician assistants to prescribe and those that did not. On the last page of the handout, you'll see that these areas in black are those states which do allow physician assistants to prescribe, 32 plus states plus the DC. The states in the southeast region, which are typically underserved, including Tennessee, do not have prescriptive privilege authorization at the state level. And when you put them together, you see that this is one of the answers to the problem that we're addressing today.
I appreciate all this emphasis on Tennessee. It makes it much easier to understand these issues. Let me defer to Ms. Rasko.
Dr. Harris, could you talk some about what you would see in the area of dental services in a basic benefits package?
Well, without question, we feel that we should see some preventive measures, as I mentioned earlier. And our concern at the present time, in realizing the finite budget that we're working with in this major problem, our concern is that we're going to destroy a good system by putting too much in the basic package, frankly. We think our system is treating as many people, many persons in our population as any other system in the country, in the world. I will say, though, that we are quite concerned about the children, particularly those children who are indigent, near indigent, who cannot afford those preventive services that we talked about. We'd like to certainly see some type of child program that works far better than Medicaid does. Frankly, Medicaid for us is an abject disaster. It just doesn't work. Following that, the elderly. As you probably are well aware, there are no dental benefits in Medicare. And so many of the states do not have adult or senior Medicaid programs, and therefore there are no public dollars for any care at all for seniors. Only 4% of our total dental health care dollar is public money. And so you can see that certainly there's sections of our population that we do need to cover and we do need access for, and certainly prevention should be the first part of that program.
Well, if we could take that just a little further, since
Surely.
There's much discussion about a core benefit package. Let's take the children that you mentioned first. What specifically would you say about the design of the program for them?
I would think that we'd be looking at certainly fluoride treatments, sealants, space maintenance to prevent further expensive orthodontic care at a later age, things of that nature which are well-defined, certainly pain and suffering, eliminating that, eliminating infection. Those are things that at base should be minimum of that type of program.
And then the elderly.
Same sort of thing, except I would add adjunctive care, because one of the problems we have are the nursing home population. There just are no dollars there to take care of those folks, and that certainly needs to be done.
Thank you.
Mr. Magaziner?
Yes. I'd like to try to get a little more specific on the ways in which you think that state laws now are inhibiting the kind of greater openness that you think ought to be there. And if you could talk a little more specifically about those laws and what you would see to do in modifying them in a specific way.
There are some states, sir, that just by law prohibit patients going to non-MD providers unless the MD himself or herself refers the individual. It would be felt that if these individuals had a freedom of choice and direct access to quality care, that I'm certainly sure that we're not talking about additional benefits, but what we're talking about is increasing the pool of eligible people to serve these individuals.
Or increasing choice, you mean, for the consumer?
For the consumer,
So
yes,
you're not saying that there ought to be laws that specify things to be allowed, but rather that there be restrictions removed in terms of consumer choice?
I think, and to answer, I think there should be the restrictions removed so that the consumer has a freedom of choice to choose to whomever they would like to see.
And then presumably the funds that get carried with that consumer would then go wherever they went if
Yes,
it was
sir.
a fee-for-service plan.
Yes, sir.
In terms of if accountable health plans do form in different states, in addition to the fee-for-service sector, do you have any views on what ought to be the contracting relationships that providers would have with those health plans? In other words, what kinds of guarantees would you possibly want to see on that relationship as it emerged?
Can I make one comment on that? We would certainly, the main thing that we would like to see is to make sure that we're participating in a system that permits quality care. And the problem that we've had with the managed care, managed competition AHP plan is they may specify a benefit, but they are then under a financial disincentive to provide treatment. So we are collecting 300 to 400 complaints a month from our providers who argue they get someone into treatment who needs more care, and they're driven out of treatment by the entity. So I think from our experience in the field, I think that you can set up a number of arrangements in which they pay by the hour work or any other arrangement. But the main thing we hear over and over again is that we can't give people the treatment they need.
How would we set up a system that overcame that? In other words,
I think that there are two things that could be done. The most important thing would be to look carefully at the incentive system that you create for the AHP. To us, the best thing would be if you could separate the gatekeeper or the person making the decision about the treatment from the financially interested party. You know, in the old days, we had a system where the patient and provider would sit down and decide how much of a third party's money to spend. That's obviously too far in one direction. Now we've gone in the direction where the at-risk party, the HMO or managed care company, decides how much of the money they've already received they want to allocate to provide mental health care. So we would ask you to look very carefully at that very important cost containment mechanism and try to draw a little better balance than we have in the current system.
I want to press a little further on this because this is, as you've pointed out, a very important point for us, and we want to make sure that this gets done right. How would you do that? In other words, how can you set something up that allows a group of providers sufficient freedom to do what they think is best for their patient, but yet doesn't encourage them to do more tests and procedures because they get paid more the more they do?
Well, I'm not recommending you let the providers decide. In the inpatient setting, for example, you could have a provider who is independent of the hospital and is not going to be treating the patient and is paid by you for making the evaluation, which might cost you a couple $100, to decide whether you should spend $25,000 or $30,000 keeping that adolescent in the hospital.
So it's almost an advocate for the consumer in the system that is basically trying to balance that? Is that
for
what
both consumer and the one who's trying to make that trade-off, who doesn't have a financial incentive themselves one way or the other. They wouldn't have to be pro-consumer any more than they're pro-payer. But they would not be in an incentive where they make more money depending upon which decision they make.
Do others of you have views on that?
I think, sir, that to remove also the primary gatekeeper, to allow the consumer or the citizen to choose the doctor, but they can come in and there's not going to be the necessary test because they can do those tests, they're qualified to do them, and to render a diagnosis from there. And if appropriate, refer to the appropriate healthcare provider.
I would add that one of the things that tends to add cost to the practice of medicine is that we need to change our tort laws. To be practicing defensive medicine in this day and age is very expensive, and I urge you to include that. I know you're considering it. At the state level, you asked about some of the things that need to be changed. It needs to be carefully understood that the services that the physician assistants provide are not new services. They're not additional services. They are physician-type services that the patients require. And we would ask that language be put in that goes to the states, that things like Medicaid policies should cover our services if we provide them to Medicare patients. Currently, there are many states which will not recognize us as authorized providers, although we provide identical services.
I'm sympathetic to this because I've observed situations, for example, where a hospice patient that I visited at home, a gentleman and his wife was trying to care for him, and he needed a shot every once in a while that would basically reduce his pain. By law, it had to be administered by a physician, but they couldn't get a physician to come to the home. And so the dilemma was that at great pain and suffering to that individual, they would have to either bring him to an office, but they couldn't have a visiting nurse or a physician's aide or whatever deliver the shot, even though they would have been quite capable of doing so because of the state law. So I'm sympathetic to it, but then the argument on the other side is, you know, how do you prevent against things running wild and the consumers not being protected from, you know, anybody claiming that they're capable of doing something they're not capable of? And I guess it's that balance that I'm reaching for.
That's why you need state laws, though. It's not anybody that can do that. There are very specific state laws. So you would open it up to a broader spectrum. You wouldn't just take away any state law. You would just basically open up the spectrum in terms of they would have to be licensed professionals practicing within their scope of practice.
Yeah. Ms. Betts? Yeah, I'm sorry, ma'am. Yeah.
I think that it is always clear that when you're trying to change a system and open a system to new services and new delivery points, the issue that you said on the other side is always raised with quality. But I think we have to look at the quality issues that we're concerned with now. We don't have the greatest longevity in this country. We have a tremendous problem with infant mortality. I could go on and on.
Sure.
So I think that something needs to be changed, and I think you've heard from each of us that what needs to be changed is the delivery system, not just how you pay for it.
Right.
When you look at years, decades of excellent education in nursing, you know that nurses are educated to do very high quality care throughout the country. It is inconceivable that we are doing excellent quality care, full prescriptive authority, full reimbursement in the state of Washington. And I'll pick on my own state, Tennessee, for a minute. You come to Tennessee and certainly the care of advanced practice nurses is more suspect. I think the way that you could really make the system work for the consumer, and that is what nursing is concerned about, having a system that works for our consumers, is that you could do a capitated system that competes on cost and quality, and that the consumer know the quality outcomes. Nurses have no problems competing when our consumers know how well we do, but we do have serious problems not being able to compete on a level playing field where the first dollar always goes through another provider and our care is seen as an aggregate cost instead of a substitutable cost. Home care, which you mentioned, is so important, not just for cost issues, but also quality. There are many individuals who can be cared for and want to be cared for in their home at much less cost and much more humanely. And I urge this new system to look at alternate delivery sites. Hospitals and physicians' offices should not be the care sites in the new decade.
Can I add something on that? I just want to emphasize that part of the cost has happened through the years because of the resistance of the medical establishment towards licensing of other professionals. We have now, we're licensed or certified, social workers are in every state in the union, but the medical establishment fought us every step of the way because it was thought to be a purse string issue. And to the extent that the American, and that's the answer to having services that you know are good services, you know, by having people, you know, licensed. And the issue of the turf battles have to just disappear if we're going to save some money.
Could I add one comment to that, sir? I think when you suggested opening it up, I think that's fair. In my opinion, how do you contain it, I think goes back to the individual licensing boards. And I think what you need to do is to make it so that they do peer review on all their licensees. I think that is part of the way that you can ensure that not only the quality of care will be delivered, but that the consumer is being considered in everything that's going on.
And that plus, but the scope of practice is really the protection also, that as long as that's clear.
They have to work within the laws of each individual state, sir.
General Reno.
I'm interested in your thoughts on drug treatment, and one of the things that I've discovered is that a number of you at this table provide wonderful drug treatment, and others in your profession, whether it be nursing, physician assistants, social workers, and psychologists, say, oh my God, don't give me that. For the four of you, if you were to design a system, how would you attract the best people? How would the psychologist work with the social worker? Would you put it into the regular drug treatment, into the regular program, or treat it separately? And how would you provide the continuum that got them out of the hospital into alternative housing, into residential or daycare, drop-ins, 24-hour emergency service? And